Unmute. You are this?
Yeah, Dr. Saklesh, am I?
रेडी है? ठीक है बेटा, ठीक है, तो अपना डॉक्टर बी एस तो फिर
I don't think we need a mic. Well, friends, the last day of the conference, it usually happens that people are not there, but in these circumstances, it is very much applicable to this day. Well, I have been asked to start the session. Accordingly, I am doing that. And the first person who's waiting since long is no less than Dr. B.S. Rajput from Bombay. And he will be talking to you on something new, stem cells in osteoarthrosis. Dr. Rajput, please. Don't worry, you take it as the hall is full.
Good morning, Professor Yadav, Professor Tuli, friends and senior colleagues. I am thankful to IOA for giving me this August opportunity, and I would like to do justice with the subject stem cell therapy in osteoarthritis knee. As you know that osteoarthritis is the commonest joint disease of the elderly age group, and currently more than 16 crore Indians suffer with osteoarthritis. Approximately 4 crore Indians would need knee replacement in the coming years as expected, which would become a huge financial burden on society and family. So basically, this osteoarthritis is a chronic degenerative and inflammatory disease of the whole joint, which is progressive and irreversible and characterized by degradation and loss of articular cartilage, osteophyte formation, subchondral bone remodeling, and inflammation of the synovial membrane. It is basically caused due to advancing age and with the genetic predisposition, trauma, poor knee alignment and instability, increased biomechanical stress due to obesity. And obesity has become a very important role in the as a causative factor for osteoarthritis, as it causes activation of the pro-inflammatory cytokines like IL-6, 8, 1, TNF-alpha, and IL-18. Simultaneously, it causes suppression of the regulatory cytokines like IL-10. If you see, in the joint, there is always catabolic and anabolic process which is going on. And if the fat pad, especially the infrapatellar fat pad, gets inflamed, it tilts the balance towards the catabolic process, and there is release of the proteolytic enzymes which causes synovial inflammation, increased production of the MMPs, increased chondral degeneration and poor chondral synthesis, and simultaneously TGF beta also causes osteophyte formation. So what is the role of stem cell therapy in osteoarthritis knee? As you know, the mesenchymal stem cells are the mesenchymal stromal cells are appropriate for the treatment of the stem cell for the osteoarthritis because they have got the anti-inflammatory effect, immunomodulatory effect, regenerative potential, and they can be easily procured from the various tissues like bone marrow, adipose tissue, umbilical cord, or the blood. These are replenishable and largely safe as no major side effects are noted in last 20 years. We have various options. If only grade 1 or grade 2 ONE is there, we can give PRP. If grade 2 to 3, we can give PRP with the stem cells. And if grade 3 and 4, we can give PRP stem cells with the surgical procedures like PFO or STO. And these cells can be autologous, like mononuclear cells or the mesenchymal stromal cells, or maybe allogenic, like the umbilical cord derived mesenchymal stem cells. Again, autologous can be bone marrow derived, adipose tissue derived, or the peripheral blood derived. So you must be wondering what happens when the stem cells are transplanted. You see, whenever the stem cells are transplanted into the knee joint, they give first induction response. And as you know that after transplanting, most of the cells undergo apoptosis after releasing the growth factors like cytokines, extracellular vesicles, and the remaining cells which are the MSCs, they get activated by anti-environmental stimuli and starts first induction response, which facilitates the pro-growth environment, induces the local resident stem cells, and recruits the new mesenchymal stem cells and local resident stem cells. But how do we get sustained relief by the stem cells? This is important because you see in the follow-up, these MSCs give sustained release of the growth factors, cytokines, exosomes, induction of the local resident stem cells, and recruitment of the new MSCs and local resident stem cells. And these local resident stem cells and proactive environment helps in the sustained relief in the osteoarthritis. So this is the question repeatedly asked, whether this stem cell treatment is permanent or it has to be given repeatedly. So there is the answer that mesenchymal stem cells, once given, they give first induction response. They try to change the catabolic process into anabolic process. And when you give the repeat MSC injection, it gives the sustained induction response. And if you don't give, it gives the limited induction response and vanishes. So it is not a one-time treatment. What is the route in administration of these MSCs? Ideally, it is intra-articular, which is given in the suprapatellar pouch, but should be given in infrapatellar fat pad and suprapatellar fat pad also, as they work as inflammation regulators. Also, subchondral bone for the better availability, viability, and the longer retention of the cells. The doses varies from 10 to 100 million according to different researchers. As far as safety profile is concerned, MSCs are largely safe and effective, and hardly any important side effect noted other than post-injection temporary pain, local swelling, or the infection at the iliac crest harvest site. If we just review the literature, we found that this paper was published in 2016, and it was regarding the mesenchymal stem cell therapy for osteoarthritis knee, a 5-year follow-up. And they showed that the patients improved on all the parameters at 6 months, and but they started deteriorating after 6 months. But even at after 5 years, they were better than the baseline. When I went through this paper, I found that they injected only 8 to 9 million cells MSCs per joint. So in my opinion, that was not the sufficient number of the stem cells. This paper of mine was published in 2018, where I did the retrospective analysis of the autologous bone marrow derived mononuclear stem cells in the management of degenerative arthritis. And I showed that it could be a promising way to reduce the signs and symptoms of the degenerative arthritis knee. And it can be concluded that a second injection or the multiple sittings may be required in patients with severe osteoarthritis or higher grade OA. And we showed that the patients improved on all the parameters, including VAS, WOMAC, and the walking distance. We also showed that with the stem cell transplantation, there was definite repair of the articular cartilage breach and disappearance of the subchondral bone cysts. Again, in this MRI, you can see the patient's subchondral bone degeneration and cysts have improved over a period of time. And even in the severe cases where the joint line was not seen, could be seen later on after stem cell transplantation. In this review analysis, they did the review analysis regarding the mesenchymal stem cells for treating the patients with OA, and they found that the MSC treatment significantly improved knee pain and self-reported physical function in patients with the knee OA. Again, in this publication of a phase 2B clinical trial, they used the adipose-derived mesenchymal stem cell transplantation, and they showed that the patients improved all the parameters, including WOMAC, VAS, and SF36 scores. And they also showed that there was definite increase in the thickness of the cartilage, and it can be used as a therapeutic option. They use the word therapeutic potential of the intra-articular injection of the adipose tissue derived MPSCs in the treatment of the osteoarthritis knee. This is very important that in this grade 3 and grade 4 of the osteoarthritis, they use a stromal vascular fraction. And in this study, the researchers advised that prior conducting a total knee arthroplasty, the treatment of the arthritic knee joints with intra-articular injection of the autologous adipose tissue derived SVF should be considered as a regenerative treatment option. They showed that there is definite improvement in the cartilage thickness and the repair of the breach. In this paper again, they showed that the autologous bone marrow concentrate means you need not to have the MSCs from the lab. You can just make a bone marrow concentrate. And they also used lipoaspirate in this case, and showed that the encouraging results and the positive outcomes without any complication, and advice for the treatment in osteoarthritis knee. In this, again, this is mini review and recently published 2019 regarding the cell therapy for osteoarthritis knee. And they showed that intra-articular injection of the MSCs in the knee is safe, simple, does not require a surgical procedure, provides pain relief, improves function, and enhances cartilage quality. This was again paper in the Journal for the Orthopaedic Translation, a review article where mesenchymal stem cells in the osteoarthritis knee, and they did the systemic review and meta-analysis, and they found that MSC therapy is a safe treatment, has a great potential as a clinical therapy in patients with OA knee. And if you see that they studied the final 19 studies included, and most of the studies involved bone marrow or the fat-derived mesenchymal stem cells. Now, I will tell you about my combinational approach for stem cell therapy and osteoarthritis knee, where I use bone marrow, MSCs, PRP, and fat. I inject 100 million mesenchymal stem cells, which are in the 3 ml suspension, These are Passage 3 or P3 cells, along with 1.5 ml of the freshly prepared activated PRP and 0.5 to 1 ml of the liquefied fat as a scaffold. The steps means initially we aspirate the bone marrow 60 ml for the single joint, send it to any Indian approved FDA approved lab. They supply 100 million MSCs in 3 ml suspension after 1 month. Preparation of the PRP is done just before the procedure. Extraction of the 1 to 2 gram of the fat from the infrapatellar fat pad is done under local anesthesia. And we prepare the liquefied fat in the form of 0.5 to 1 ml liquid. Now we activate the 1.5 ml of the PRP by adding 0.5 ml of the calcium chloride or the calcium gluconate and gently mix it for 3 to 5 minutes so that it gets activated. Once the fluidity of the PRP starts reducing, we inject it immediately in the medial joint space of the knee joint, which is followed by injection of the liquefied fat in the same area and the MSC suspension in the same area. So aspiration of the bone marrow. So preparation of PRP. Sorry. This is preparation of cells. Then if you see 2 vials are there and which are sent by the lab. And this is PRP preparation. And now you see that I am taking out first the platelet poor plasma so that I can have the platelet rich plasma. Then I am taking out the fat from the either subcutaneous area or the infrapatellar fat pad. And we make a liquefied fat 0.5 to 1 ml and inject it in the medial joint space. And then we are injecting these stem cells into the same area, and within 5 minutes patient is allowed to walk, and it has got clinically very good results as far as the symptoms are concerned. Simultaneously we are getting the documented results also, and you can see that patient is able to walk immediately after surgery, and there is no problem because it is a procedure which is done in local anesthesia and patients are allowed to walk. So in the follow-up X-ray MRIs, you can see that with the mesenchymal stem cell transplantation, this subchondral bone cysts disappeared, effusion disappeared, pain reduced greatly, gait improved, night pain decreased, and walking distance and time increased. Again, in other MRIs, you can see the subchondral cyst has disappeared, and there is definite improvement in the cartilage thickness and the breach. In this MRI also, you can see the healthy cartilage is more than on the pre-treatment. So our results show that there is definite symptomatic improvement in more than 90% patients after 1 month. Improvement is documented as improvement in Womack, WAS scores and SF scores, which persisted for more than 12 months. There is definite cartilage regeneration seen in MRI and symptomatic improvements even seen even in grade 3 and grade 4 OA patients. So take home message is stem cell therapy has emerged as effective option in management of osteoarthritis knee. These cells can be procured from bone marrow or adipose tissue easily, and it can be repeated as per the requirement of the patients. Addition of PRP or the fat improves the results and works as a scaffold. It is a good clinical option even for grade 3 or grade 4 patients before TKR. Thank you, sir.
Thank you, Dr. Rajput. Very nice.
Thank you, sir.
Stimulating. Wherever stem cell is published or spoken, people think that it's something very new and they go in for great enthusiasm and listen to the paper. Any question? Professor Tuli, I know you would like to ask.
Sir.
Any cell has a destined apoptosis, wherever you obtain it from.
Please get closer to the mic.
Ah,
So whenever you give or place a stem cell in any cavity, any place, it is destined to die according to the rule of apoptosis. So it's a short-term effect. I know that you mentioned that these cells induce other cells to form stem cells. How effective they are, I'm not very sure. If they were permanently effective, you didn't have to repeat them. I think most of these studies get biased because these studies or these treatments are not done in isolation. The patient is already on the conventional treatment. The same thing happened with magnetic therapy for fracture healing. Nobody stopped the conventional treatment of fractures, and still they were giving magnetic things. They thought magnet is doing it. But when so many factors are being used simultaneously, it is really very difficult to give credit to stem cells, though I'm a believer that we should make the best use of that potential.
Thank you.
Thank you, sir.
You want to answer?
Just couple of.
Please.
Thank you, Professor Tuli. Actually, as I tried to explain during my presentation also, that the modus operandi of these cells is by releasing the growth factors and stimulating the resident stem cells or the satellite stem cells, which are always present there. And we need repeated injections because this is not a permanent treatment and it can be repeated as and when required. So you are absolutely right, but I would like to say it should be tried as a clinical option for those patients who don't want to go for the knee replacement, or they are in the earlier stages, they are younger and they are not fit for the knee replacement so early.
Well, Dr. Rajput,
Sir.
I think it's a good start, but it will go a long way. One, standardization of the technique, standardization of the preparation of the stem cells. You have to make it more specific and authentic. You said we are preparing these stem cells. You have to make the process more elaborate. One, how many injections? At what time? What interval? Where should you give? If you give into the joint cavity on the medial side, it does go to the lateral side also. It gets diluted. Agreed that mesenchymal cells have got a capacity and potentiality to get converted into all those cells where it is required, like osteocyte and osteoblast. But it's very difficult to swallow, Dr. Rajput, that if you inject stem cell into the knee cavity, it will produce more stem cells, because stem cell is not an ordinary cell. So I think this study, one can talk a lot more about it, intervals, why grade 3 and 4, why not grade 1 and 2? Because grade 3 and 4 will develop deformity. And if there is a deformity, it's absolutely certain that the medial compartment will be compressed if it is a varus deformity.
Definitely.
And a high tibial osteotomy, as you said, you are doing, because I had the privilege of talking to him before the session started. So I think a high tibial osteotomy is a very, very good operation for closure of the medial compartment of the knee. A lateral closing wedge osteotomy is a very good procedure for this. So I think you have to separate it out, because you said that you do a lateral closing wedge osteotomy and also injection.
Just to give
You have
long-term
to
relief.
differentiate whether it is high tibial osteotomy that is working or it is the stem cell. Anyway, it is a good start,
Yes,
and
sir.
we look forward that you will be presenting more papers on this subject, disputable subject later also. And it's a very good subject you have taken. We wish you all the best,
Thank you, sir.
and I
Thank
hope
you.
you will come next with some more information for
Yeah.
the audience. Thank you very
Sir,
much.
just a very small request that we should promote these stem cell trials in various medical colleges, since you are here and Professor Meena is also there. Because these trials are not being conducted in good government colleges, so they are not getting that authenticity and the support. We want-
Standardization is very important. One is, how do you
Yeah.
procure? How do you procure the stem cells?
No, sir.
Are you sure
Huh.
that you have procured the stem cells? Because the preparation in the laboratory, as you have shown, is right.
No, no, they have
But
got-
there should be an authenticity
they-
that these are stem cells and not mesenchymal cells.
Sir, there is a definite quality analysis report which comes and says this number of the cells, this passage is
Sir,
there.
we will
and-
believe you, not anybody else.
That is-
And anybody else can be a false one.
Okay,
We believe, Dr. Rajput,
okay.
you try and work out that I have done this and for such a long time. The audience will believe you and give you a clap.
Thank you, sir. Thank you very much. Thank you.
Sir, may I
The
ask a question?
second, yes,
Dr. Rajput, my question to
Oh.
you, sir. Actually, you talked about conservative management of osteoarthritis by means of stem cell.
Ah.
Actually, I had a query, I mean, a bit digression from the subject.
Ah.
Stem cell therapy for paraplegic spine. Initially in 2000, there were a lot of promise, there were a lot of newspaper reports, etc. So like a far-sighted future, can we have a dream that someday stem cell, I mean, just philosophical question, I am not asking you for a level 4 evidence or level 1 evidence. Can we, I mean, think or can tell our patients that someday 20 year down the line, 30 year down the line, we will have some solution for these traumatic paraplegia 0/5 by means of a stem cell or some other magical drug?
We are already using stem cells. And as I was discussing with Professor Yadav, that in cervical spinal cord injuries, we are not getting very good results. Not even in upper thoracic, but in lower thoracic and lumbar spine, we are getting reasonably good results. And we take patients only when they don't improve at least up to 6 months after injury. So natural healing process time we give patient. If they don't improve, then we give autologous bone marrow derived mononuclear cell transplantation as intrathecal cells. Okay.
Right, sir.
And we are getting very good results. And unfortunately, I have not published the paper because I am more interested in joints, but others are publishing. And even Professor Chabra from the Spinal Cord Institute,
Yeah.
he published this paper several times, and he said that definitely there is improvement in the patients, although it may not be in the you cannot measure it in MRI or in other things, but the quality of life definitely improves there.
It is improving.
And I have several patients which are
It is
improving.
improving.
Yeah,
Then
yeah,
You will have to publish it someday.
Definitely, I would like to publish.
One
Yeah.
more question, may I
Yeah.
have? One.
yes.
Then my next question is to both Dr. Rajput and Professor Yadav, the panelist. You were talking about osteotomy management, in
HTO,
management,
yeah.
HTO, in the
Huh.
management of osteoarthritis. There is a school of thought who directly replace. There is a school of thought who want to salvage the joint. Professor Yadav, in his talk at Vardhaman Mahavir Medical College, circa 2017, September, before we met at IO House for declaration of Dr. Meena's result, we were talking, you were exhorting Professor Malhotra that PFO is a very good surgery. This can save many joints going for unicompartmental uni replacement. That was the flavor of the talk. I just was privy to your discussion. I overheard it. So after this PFO has been roundly overused in various by the medical fraternity with courtesy and help of insurance companies, etc. And most of the time results are not very good as long as I read or as follow the patients. So what is your talk about PFO, proximal femoral
Fibular
fibular
osteotomy.
osteotomy for osteoarthritis?
Sir, osteoarthrosis is a degenerative procedure which involves the medial joint line more than the lateral one, and a high tibial osteotomy, closed wedge osteotomy is the answer. I don't want to dilate in much, but Chinese have brought out a high fibular osteotomy, which I don't think will last long. Why? Because the defect lies in the tibia. Defect lies on the medial joint. Why not do a proximal tibial osteotomy rather than doing a proximal fibular osteotomy?
Correct.
Immediately there may be psychological or physical good results, but in long run, high tibial osteotomy, this is a subject which is very close to my heart. I have done even 5 osteotomies in a day because of the patients come even from Punjab to Haryana. They wanted me to hold a camp in Punjab, Batinda area. What I mean to say is, why not to do a high tibial osteotomy, which sounds much better, because I have no experience about high fibular osteotomy, because it may that the forces are changed, but it may not last for long. Whereas a high tibial osteotomy will at least cover 5 to 10 years if the patient keeps on doing quadriceps exercises.
Yes, sir. And
So I think high tibial osteotomy has got a great future if we don't do a TKR in very minimal cases on the medial joint line, advise a TKR. No. Capital N and capital, I have seen TKRs being done even in normal knee joints. This is unethical and uncalled for and will not last long, because people will understand what is true and what is false.
True, sir.
So I think to avoid all those medico-legal problems for tomorrow, we should switch on to simpler, biological, effective, and need-based procedures for these things. Thank you.
Thanks, Professor Yadav.
Yes, sir. Your question?
Regarding stem cells in paraplegia, in one of the international conferences, Rajshekharan from Coimbatore told some of the cases which were injected with stem cells, in some of the cases, they differentiated into malignant cells and killed the patient. What is your opinion on this?
You may be correct, but whatever we are using, that is autologous bone marrow cell concentrate. And in last 20 years, none of the papers have shown these results. And I'm not sure regarding which type of the stem cell was injected in that case, and where was it injected. But as far as mesenchymal stem cells are concerned, till date, no paper has shown that it converted into any malignant cells.
Thank you.
Till date.
Well, I do not know. If Dr. Rajshekharan has said, he must have read it somewhere, and he may be right. But at present, we cannot. The world is so turbulent about stem cells that whatever somebody says is taken as right. Whereas, as I said day before yesterday, that whatever is published, I repeat, whatever is published must not be taken as a Gita or Puran. We have got a brain, and we can intersect as what is right and what should not be right. There are people who are publishing false research. False research, as I said, it is written in editorial of the Journal of Bone Joint Surgery. He writes, editor-in-chief, that majority of the research which is being done today is false. False, false. Where do we stand? I've got a slide. Editorial, editor-in-chief of JBJS. What else you want? So please don't follow the world blindly that so-and-so says like this. No. What we should judge that he is a man, he is not a woman. People are trying to prove that he is not a man, he is a woman. How can you believe it? Now to say that stem cell will make the patient die, it will take time to prove this hypothesis. These are theories, if somebody has published it. But it will take one long time. I think it's a subject which will require authentication for long, long time. Second question, second paper.
Next speaker, Narendra Singh, Dr. Narendra Singh Kushwaha, periprosthetic joint infection in TKR. He is not there.
He is not there. Third one.
Dr. Nirmal Kumar, THR in fracture neck femur, primary to complex scenario.
A very good morning to you all. And at the outset, I would like to thank the organizers, especially Professor R.C. Meena sir, Dr. Arun sir, for giving me this opportunity to talk before this August gathering. It's always a mixed feeling to talk before stalwarts like Professor Tuli sir, Yadav sir, because they are the people whom we grew up listening to and looking forward to. So I will just start my presentation. The topic is total hip arthroplasty for fractured neck femur, primary to complex scenario. Well, fractured neck femur has always been an enigma. It has been a difficult thing to tackle. There are so many controversies associated to it that still we don't have answers, or rather we don't know how to ideally deal with these conditions. And since neck femur fractures are usually sustained by geriatric age group, so that makes the issue much more complex. And the whole presentation will revolve around how to tackle different scenarios. And I think this presentation, younger arthroplasty or other people who are interested more in arthroplasty, they'll be able to correlate themselves easily, because I have tried to present a few cases which even I slowly started taking up after having done certain straightforward cases which didn't involve much of planning or skill. So I've just tried to present and at the same time put forward my shortcomings and the challenges which I faced. And I'm sure that at the end, we will have a good discussion and I'll be able to get some
Please
good
start
inputs.
your paper, doctor,
So,
because time is limited.
so indications, definitely we all know, and there always has been a debate like what to do, go for, whether hemi or total. But in my view, any active patient before injury and who is expected to have a good life expectancy and definitely will be able to withstand reasonable anesthesia, is medically fit. There, the option of total hip arthroplasty should be explored because functionally, total hip arthroplasty is bound to give a better result compared to hemiarthroplasty. Compared to the other scenarios, total hip replacement for fractured neck femur has its own set of challenges because usually it is a lax situation. So soft tissue balancing can be much more difficult than in case of arthritic hip. And since it is associated with old age, so comorbid conditions have to be taken into account. whether it's like whether to cement or not, and whether we really should go for any complex surgery. The limitations on the part of the surgeon, expertise and experience has always been a major factor why most of us are not in favor of THR, and we try to kind of do away with THR and try to do more of bipolar for fracture neck femur. Surgical approach, lots of debate, but I have been doing all my cases by posterior approach. That's how I'm trained and more comfortable with. I don't find any of the so-called complications, that is posterior dislocation, at least because of this approach. So approach hardly matters. Prosthesis choice will differ from person to person. There was a good talk yesterday under Indian Orthopaedic Association where they talked about how to choose the stem and all. What actually matters at the end of the day is a good outcome, which will definitely be determined by properly seated acetabular cup and femoral stem. So that in turn will decide the longevity of the implant and the functional outcome. Regarding stem, definitely the dictum goes as like in all other replacement, I mean THR. Even for neck femur, they hold good. So you start with templating, and then you decide what design stem you are going to choose for your particular patient. So it usually depends on the anatomy that can be altered because of bowing or some previous fracture. And proximal or distal fixation, that's two parts where exactly we need to decide what kind of a stem we choose. The version and offset are definitely important, like in any other THR. What I would like to emphasize here is we always should have option of high offset designs so that we do have an option of balancing the hip without overlengthening the limb. So we do need to have backup of high offset designs. Regarding the cup, again, position, inclination, and version is very important. I think most of us are well versed how to do that. Design, not much to talk about. But then dual mobility cup and constraints. These two are like, again, very much needed in case of fracture neck femur, because there are certain situations where in spite of doing the best job, you will find the hip dislocating on table. And that's a very bad idea to come out of the surgery with a dislocating hip on table. So in that scenario, either you have to switch over to dual mobility or you need to think of putting on a constraint design. So these are the time-tested mantra which is evolving, and lots of controversies again. But more or less, we do understand and agree that the center of rotation of the hip has to be restored at any cost. And that starts the moment you template a case and you make up your mind where exactly you want your cup and stem to land. The combined anti-version is a thing to look for. And of course, we know it's slightly higher on the female side and lower on the male side. Spinopelvic relation is again being talked a lot about, because especially in the elderly population, you may have degenerated spine and you can have kyphotic and scoliotic deformities. So you may have situations where you may have a very stable prosthesis on table, but once the patient assumes different positions, the hip may start dislocating because of changing pelvic position. Soft tissue balancing, suck shuck test, and check for soft tissue tension. And the best way to do is you look for the tightness of the iliotibial band, and also you make the limb, keep the hip in neutral position and flex the knee. If the leg kind of shoots and jumps, then that is probably you have over lengthened. So over lengthening is again something which needs to be emphasized, because what happens is you never want an unstable hip, and in that zeal of creating a stable hip, probably if you don't have a high offsets design, or sometimes you're not very vigilant, you will end up balancing the hip by over lengthening. So that is something again which you can have legal issues, and one needs to discuss with the patient preoperatively and take a proper consent for that. Cementing definitely is very challenging, and cementing needs lots of efforts and extra care, because the whole longevity of the implant depends on your quality of cementing. So what works probably, I think approach hardly matters. All approaches are okay, whatever you are comfortable with. Prosthesis, uncemented, definitely in young population, and hybrid, because UK registers and all, they are more in favor of hybrid. So by hybrid, I mean cemented side, cemented stem and uncemented acetabulum. Since I am a posterior approach guy, so I would be suggesting like we need to really have very good idea and we need to execute this capsular repair very well. Otherwise, we will be facing that dreaded complication of early dislocation. Now I'll just start with the cases. These are all complex cases. They're not straightforward primary neck femur situations. This is like a dislocation hip with fracture head. And the patient was quite young, so naturally the choice was an uncemented hip. Case 2, again a female 48-year-old. She sustained fractured neck femur as was expected. The primary surgeon tried to fix it. But the problem was, I think there was a malreduction and it was not properly compressed as well. So it started failing. The patient had unbearable pain and she presented to me quite late. And she was already walking with the help of crutches and limping, and she was in big pain. So it was a case of failed osteosynthesis with screws in situ. So the workup to rule out infection was done. And once we are sure that there is no infection, we, sorry, the video seems to have turned around. So this was her presenting video. So the pertinent questions were what to do. Of course, there was no further question of salvage. So it had to be replaced, whether hemi or total, considering her age and activity level. I think THR was the right choice. And I went for ceramic and poly just to give her extra opportunity for the implant to have a longer life. Surgical approach, of course, posterior, and that's that previous surgical scar. Now, what is important here is to note that we should not be in a hurry to remove the screws. We should just try to dislocate the hip with the screws in situ. Otherwise, things are going to get complicated. And that's the video where dislocation is never an issue here. But the only thing is, if we take out the screws first, then we will be struggling with a retained neck, and that will be consuming more of our time. So good exposure, as is like said, unless you get a good exposure, you won't be able to do a good reaming, and you will be placing the cup in some compromised position. So 360 view, that's very important. That's a closer. So I never kind of try to keep the incisions short or kind of give a cosmetic this thing, because what is more important is to have a long incision, a good exposure, and gluteus maximus, as I always release partially because I don't want my sciatic nerve to be overstressed. But at the end, I always keep in mind that I repair whatever I cut, and that's a post-op. And after that, she had a good outcome. Then another case, operator drills were presented 8 months post-op, and this was the condition. DHS was done, the derotation screw. Again, infection was ruled out. Patient wanted only one surgery, and of course, it was too risky to try to salvage this. So I went for hybrid. Now, what is important again here is the problem of cement leakage. And so what we do usually is to put back those screws which were retrieved just to, and put a thumb along the hip screw so that the cement doesn't leak out. Still, you may have situation where medially you can have certain cement leakage, and that usually is never a problem. Another case, male, he had a trivial fall and he already had fractured neck femur some 15 years ago, and multiple times he was operated, and he was having a bipolar prosthesis there. On admission, he was found to have diabetic, and having optimized him, as per our understanding, we took the case. That's his pre-op X-ray. We can see the acetabular erosions, and he did have painful hip before he sustained that fracture, but somehow he was managing. So these were the issues. The acetabulum was already eroded. There was a long oblique fracture. So the implant definitely had to be revised. And there was a calca defect which was visible over there. So these are the original plans where I had kept everything ready on table. So I thought of going in for distal fixation, that solution stem and the usual cup. And then just to stabilize the fracture, circulars, cables, SS wires, everything was kept as backup. And also the distal femoral long LCP plate of the opposite side, so that that could be turned in case I'm not able to surpass the fracture sufficiently in terms of length. But things were going well when suddenly the patient had cardiac arrest mid-surgery. And later on workup, we found that the ECG was overlooked and probably he should have undergone echo as well. But that was overlooked again by physician and anesthetist. And finally, that's his different surgical scars because of previous surgeries. And that was a calcar defect which was visible per tape. Now again, one thing I'd like to say is bipolar, what was retrieved in that case was still very much functional. So it was first time I saw bipolar, which was there for more than 15 years. That was not still jammed. So it was like, that works, seems to be working. So that's the immediate post-op. And after that, cardiac part was taken up, and he was referred to another hospital where the patient wanted to go for cardiac consultation. And that's his further follow-up. And without further sinking or any significant sinking, since this is a distal fixation stem, solution stem. So there are certain other situations where the solution stem, that's a distal fixation stem, can have its own utility. Another case, no known comorbidities, fracture neck femur. He again had some 16, 18 years ago. The patient came for TA rupture and then he started exploring, and I could find that he used to have pain in the back because of this thing. So later on he got convinced and he wanted whether to explore the option whether he can have a painless hip and whether he can have a limb length discrepancy addressed. So he was taken up for THR. The challenges were manifold in this case. The most challenging was how to bring that overriding femur down. So it needed extensive sequential soft tissue release, and osteotomy, of course, subtrochanteric osteotomy. So the implant of choice was SROM because I don't think there is anything more modular at present than SROM. So that's the immediate post-op. But again, probably we didn't counsel the patient well, and patient, because of constipation, I overlooked that part. Usually we happen to overlook that part. So most of our patients do have constipation. Many times they are more worried about their constipation rather than the actual fracture or condition with which they are admitted. And patient, while in an attempt to pass stool, tried to squat and he happened to dislocate his hip. And so this was the situation. I didn't know what to do now because already so many things were at stake. So I tried a closed reduction, failed. So I took for open reduction. And on table, I could find the capsule repair, which I had done probably in the best possible manner, was torn. There's a flake of bone coming out from the GT with majority of the abductors still intact. So that was repaired with ethibond. Cup, liner, everything, stem was found to be stable. The version was maintained. So I didn't do anything with that. After giving a proper wash and repairing the abductors, I just closed it back. And that went on to unite well. That's before surgery. And so ISROM is very handy implant. It has got the maximum modularity possible. These are the different modular implants which are available. But the advantages which ISROM gives probably is not present in any of the other implants. So in
Anywhere
other
near
case,
time.
so I'll just be concluding in the 2 minutes, sir, not much of this thing. So another case, again, this thing, the lady came with this pain and after a trivial fall, and to my surprise, there was severe protrusio bilateral. She had fractured neck femur. But like I tried to explore what complaint she had before fall, and she was very much comfortable. And all she was interested was to get rid of this pain because what she happened to sustain after injury. So plan was THR, there was no other way out here. Protrusio case, so the cup had to be lateralized, that was the main thing. I plan to use the mosselized bone graft from the retrieved head and cemented THR for obvious reasons. The cost was also a factor, again by posterior approach, that's the mosselized bone graft. What is important here is that while you put the mosselized bone graft, then the reaming has to be reversed. And if you happen to do it in the usual manner, then that will further crush the graft. So to a reasonable extent, this could be, I should have used mesh, but this was one of the cases which I was doing in the very beginning, and probably I didn't ensure that there was a case on table. So that's a post-op, and this should fare quite well. Another case, not much to share, but why I put this slide, because there are certain situations where you may not be able to accommodate normal stems. So you need to have a backup of CDH stems also. But only thing is patient should not be overweight, otherwise the implant will fail. There are certain situations where you can have local skin conditions which can be very bad, like pre-existing scar of a burn. But after consulting plastic guy and all, they assured me, and I went by my usual plan, and that's my posterior approach. And that said, for a picture, there was no, it was not deep, and the tissues inside were quite well. So again, very obvious mistakes have to be always avoided. Something like this vertical cup, this can either dislocate or will lead to early wear. So again, undersizing of the femoral step is a common mistake, where what usually I do is, whenever I broach, I try to rotate the broach. And if the broach is rotating within the femur, then probably you are undersized. And the moment you see that along with the broach, the whole femur is rotating, then you know that the size is appropriate. So my take-home messages will be, THR for fractured neck femur is to be explored in all the patients being planned for replacement. I'm not trying to sell out the total hip replacement for cases where you can salvage. Salvage is always a great idea. But for whatever reasons, if you're replacing it, try to do THR, because that is going to give you more better functional results. Functional outcome achievable in THR outshines that in arthroplasty. That's very well proven by so many studies, because you are here, you are able to play with both. And hemi-arthroplasty, you are able to just, you have under your control only the stem side and not the acetabulum side. There's a definitive learning curve, but young surgeons need to learn the tricks of the trade well. One needs to know and play around with all available armaments and surgical approaches. Approach is never an issue. Whatever you are comfortable, just go with that. But you need to understand your implants, and you need to know how to change on table the offsets without over lengthening. So debate over approach is overrated. I think posterior is being criticized unnecessarily. Posterior is a pretty safe approach if you do, provided you do the closer well. As one grows with simple primary cases, one need to graduate to complex primary to revision scenarios, and one should not be embarking upon difficult cases straight away. So keep trying new ideas, do again and again, and keep doing until you succeed in being a good arthroplasty surgeon. And I feel if we can, so can you. So everyone can do surgeries, probably, even if you are doing 10 cases a year and you are primarily a trauma surgeon, still, I think you can do a good job with total hip arthroplasty. Thank you. Thank you again for your patient hearing.
Thank you, Dr. Kuswa. Any question from the floor? Please get closer to the mic.
My question is regarding one of your cases you have shown there, a very high riding, femur was there. So what was the step to bring that high riding femur back to the original size? And second will is you mentioned about subtrochanteric osteotomies. So how much exact cut you used to take, and how to calculate intraoperatively, what are, tips and tricks to have a perfect cut and get good reduction?
So right. What I feel is, these are cases where like you deal with how you deal a case of DDH. So Crow type 2, 3, something like that. So overriding femur definitely can't just be brought by a traction. That needs extensive sequential release of tissues, and there's always a way to do that. So start with a 360 release of the capsule, and go on to sniff rectus femoris reflected head, and then you go on to sniff your swas as well, and just try to see how much it's coming. But definitely it's not going to come in this case, and you should not try to stretch it too hard also, otherwise you're going to damage the sciatic nerve. So definitely you should, next thing is you should uh, go to subtrochanteric osteotomy, and that answers your second part. So how do you decide exactly how much to cut? That's your question, right?
Yes.
So that is decided on table, because once you cut that femur, you are able to easily reduce the proximal part. And then you give a traction, and then you see how much overriding is there. So that overriding part is what decides what big chunk of bone you want to take out. And what I would suggest is, or what I practice is, I never go for an over enthusiastic cut. So initial cut will be slightly conservative, and I will try to reduce that and see. If it's still not coming, then I will try to again go and revise the cut. So that cut is totally decided by the overriding which you get on traction after having reduced the proximal part.
Thank you.
One more question, sir. If Mr. permit.
Yes.
Sir, how do you control the rotation when you're doing the subtrochanteric osteotomy? In one of my cases, it become very difficult to, address the rotational, the proximal and the distal rotation with all the, pent and drapes. So how do you address that part?
Yes, that's a very important question, because once you do osteotomy, the distal part is not under much of your control. So
Right.
there are certain ways to do it. One is linea aspera, so that's a good guide. So you know you how much mismatch is there. Second thing you can always do is you can make marking with whatever, either a blade, oscillating blade, or some cautery, so that you know beforehand that what is the mark, and you just try to match that. So while you are inserting the implant, you have to ensure that one of your assistants
Thank you.
holds the thing pretty well.
Thank you. Be short, please. Yes.
Yes, sir. Regarding posterior capsule repair, your video showed before dislocation, you have removed all the capsule. Then the repair, you are repairing only with the short external rotators, which will be flimsy. All these muscles are transverse muscle. Any amount of stitch you're taking is going to cut through only. How it lasts longer?
No, sir. Actually, I never do that. I never dissect anything between rotators and capsule. What I do, I take out everything in as a one piece.
You have already excised because we want to dislocate the hip. Without excising the capsule, dislocation is not possible. You have not done capsulotomy. You have done capsulectomy.
So which case you are talking about, sir?
What your video?
So that was
removing the screws. You said don't remove the screws and then dislocate. If you have to dislocate means you have to remove the entire posterior capsule. Having the posterior capsule removed, only if you are just closing with the drilling the trochanter, I think the repair will not be that much sturdy, hard to withstand.
Thank you. Rest you can discuss on the, if you want to answer short, please answer.
Sir, we do it in one go. We never try to dissect the capsule separately or the rotators. First thing, but the same thing was done over there. And there are two ways you can do it. You can always leave a small sleeve of tissues around the femur, or you can do it along the bone, and you can take out the whole thing and then transosseous holes, which I have shown there, and that also seems to be working well. Only thing is you need to use non-absorbable strong ethibond sutures
Thank
for
you.
that.
Professor Tuli, you want to make a remark? I'm sure. I think you are waiting for my call. I want to ask one question, Dr. Kuswa. You have presented one case of neglected fracture neck of femur where the greater trochanter has migrated up, and to make the operation possible, you had done a lot of soft tissue release, and which later on went into a dislocation. Now, a simple suggestion to that is that if you apply preoperative traction, skeletal traction in these cases, the greater trochanter will come down and you will not have to do so much of fibrolysis around the hip, and it will not go for a post-operative dislocation.
So
So
this
apply traction in these cases. Pre-operative traction, it is very useful.
so it's around more than 15, 16 years old.
Doesn't
So
matter.
I really doubt whether that is going
You
to
can
work.
apply a heavy skeletal traction weight, have patience as a surgeon, and wait for some time, and the femur trochanter will definitely come down, and that will positively make your surgery much easier. Thank you.
Thank you, sir.
Just,
The next is Dr. Ashish Jaman.
Yes, sir. I'll be presenting it virtually. So, can you hear me?
yes, we can hear.
Good morning, sir.
Very
Good morning, sir. Sir, so my job is to discuss what has already been discussed by Dr. Nirmal in short. So, Dr. Nirmal in short, so what he has discussed that we need to avoid vertical cup, we need to avoid undersizing of the cup. And there was a question from delegates that how to dislocate without doing capsulectomy. So I'm going to discuss the tips and tricks of primary THR. I have been given 10 minutes to cover all these 4 aspects: the exposure, the tips and tricks for exposure, the tips and tricks to get a perfect cup position for a perfect stem size, and to get a perfect stable construct. Now, we must remember there is no fixed rule book for these minute steps. Just a minute. There is no fixed rule book for these minute steps of cementless THA. We must keep it simple, but not simpler. Simple does not mean that we should make it a very simple thing. It's not a very simple thing, but we should keep the thing simpler. Exposure is the key. We need to see the things as clear as this to get a perfect result. And remember, bone once removed cannot be put back. So we have to be conservative in all steps that require bone cuts and bone reaming. And this single line summarizes the whole concept of total hip. The first requirement is to create as small a defect as possible, such as to disrupt the biomechanics of the bone as little as possible. So we need to create a small defect. There is no need to put large cups. There is no need to put large stems. We need to create a small defect as possible. That's the trick. Now coming to this slide, if I ask you that which angle is 45 degrees, so with some difficulty, we can say that yes, C is 45 degrees. Now, if I ask you which angle is 20 degrees, with slightly more difficulty, we can say that this B is 20 degrees. And if I ask you which line is parallel, we can say the middle one are the 2 lines that are parallel. So it's easy to identify 45 degrees, number 1. It's not so easy to identify 20 degrees, and it's easiest to identify parallel lines. Now, to extrapolate this concept in total hip, we can comfortably use freehand technique for cup abduction, that is 45 degrees. But for anti-version, we need to take help of something else, because it's not so easy to identify 20 degrees. So we require some help, and that help is given by the transverse acetabular ligament. It's easy to identify parallel lines. If we will keep our cup parallel to transverse acetabular ligament, we will be giving the desired anti-version to that patient. Now coming to a case study, I'll discuss the tips and tricks on this particular case. So this was a young male with bilateral steroid and alcohol-induced AVN. The templated size was 52. Now, the trick for exposure is, as also told by Dr. Nirmal, the partial release of gluteus maximus. It gives us 2 advantages. One is it decreases the chances of nerve palsy, and 2, it increases the posterior exposure. The moment we release the gluteus maximus slightly, we increase the posterior exposure significantly. So these are the 2 advantages of partial release of gluteus maximus. Once we have released it, the next trick is to identify superior capsule. Now, to identify superior capsule, we need to palpate the piriformis, go beneath the gluteus minimus, put a Hohmann beneath the gluteus minimus, and identify the superior capsule. Once you have identified it, now give a 12 o'clock incision on the superior capsule. This 12 o'clock incision is going to help us a long way in achieving the exposure of the acetabulum. The moment we dislocate it, our piriformis fossa should be as clear as in this picture. These are, once we have cleared the piriformis fossa, the usual neck cut length is around 1 thumb breadth, with slightly less in varus, slightly more in valgus. Once we have identified the neck and we have debrided the piriformis fossa, we just have to run in to the piriformis fossa. The question that is asked by my residents is, sir, how do you decide where to start the process, the osteotomy, and where to go? So we start around a thumb breadth from the lesser trochanter and we run in towards the piriformis fossa, and to do this we need to expose the piriformis fossa very well. Once we have taken out, we shall not rely on half circular shaped head measurement devices. It's always good to use full circular Harris femoral head gauzes, and the size of the head is exactly the diameter of hole through which the head could just pass through. So now we know that head is of say 48 size. So usually the cup will be 4 millimeter more than the head size. So if the head is 48, the cup will be most probably in 90% of the cases you will get a 52 cup for an uncemented hip. Once you have done the osteotomy, you can see the acetabular cavity. First, you put 2 pins, one in the posterior superior aspect, one in the posterior aspect in the ischial tuberosity. Then you put a cobra retractor with a small tip. Now you can see the posterior aspect, you can see the anterior aspect. Then you must be aware of the anatomy of the obturator artery. There is no need to use long anterior lever. We just need to have a small tip anterior Homan. We must be able to appreciate the anatomy of reflected head of rectus femoris. We have already given an incision in the superior capsule. Then you dissect out the inferior capsule and then give an incision into it. So now the incision in the capsule is from 12 o'clock to 6 o'clock. The moment you give this incision, you can very well reflect it and can dislocate it without the need for any capsulectomy. And this is true even in the cases of protrusio. So even in protrusio, if you are giving an incision from 12 o'clock to 6 o'clock, you can very well dislocate the hip comfortably. Now in some cases, in some flexion deformity, you need to incise the anterior capsule also. To incise the anterior capsule, we must be aware of the anatomy of the anterior capsule and the psoas, iliopsoas. Iliopsoas just abuts the anterior capsule anteriorly, and if after putting anterior retractor, anterior wall is not visualized, then as given in Campbell, we can very well and comfortably remove the incise the anterior capsule. In posterior approach, if we are keeping the knee extended, the nerve is going to be stretched. So to keep the nerve relaxed, whenever you are working on the posterior side, keep the hip extended and knee flexed. Now coming to the next step, the acetabular reaming. So that was all about the exposure. For acetabular reaming, we assume that our patient is dead lateral, but actually that is not the case always. So we must have some patient-specific landmarks rather than using floor or OT table as a landmark for cup abduction and cup anteversion. There should be some patient-specific landmarks. So one such landmark is transverse acetabular ligament, in which we have to keep the cup parallel to transverse acetabular ligament so as to get the desired anteversion. So the ideal word is that the cup should be parallel to tail and cradled by the tail. If it is, in this case, it is too anteverted, in this case, it is too retroverted, in this case, it is too deep, and in this case, the cup is too high. So the line is that the face of the cup should be parallel to and cradled by the tail. In acetabular reaming, we medialize the cup and gradually expand till we get the catch. This is the whole concept. So now there are 2 ways to do it. One is the turtle technique, one is the hair technique. In turtle technique, you start with a vertical small reamer and then gradually expand from beneath to periphery. In hair technique, you start with a large cup and directly start from periphery to beneath. Overall, the subchondral bone, particularly in the periphery, must not be reamed, and the reamer must sit fully in the acetabulum. In acetabular reaming, palpate both the columns and medial wall regularly. Do not drift posteriorly. In small patients, use 1 mm incremental reamers, and with the last size, slightly ream the periphery by back and forth, up and down movement to remove the peripheral blocking sclerotic bone. If the cup is already close to hemisphere, you finish reaming in 4 reamers. Like this. Yes, sir. Okay. If the tab size is for 52, you start with 46, 48, 50, and finally 51. Once you have gone to 51, you use a trial of 51. Now remember, trials are more malleable. So if you have reamed by 51, and if your company provides odd number trials, not all company provides that. If your company provides odd number of trials, then with trial, you should be able to insert the trial easily as compared to the cup. The final aim is that the dome is the slope part. The dome should be hemispherical, and there should be punctate bleeding at three sides: the sides of the ilium attachment, ischium attachment, pubis attachment, with little or no bleeding, no punctate bleeding on the medial side. Now, if we want to quantify the reaming, quantifying reaming is a difficult thing. It's a subjective thing. Reamer size is progressively increased to remove cartilage until healthy bleeding bone is exposed, and the dome of the acetabulum is hemispherical. Remember, the dome is sloped, so the whole aim of reaming is to make the dome hemispherical. Rest of the acetabulum is already hemispherical. We just have to remove the cartilage and get the bleeding subchondral bone. It's the dome of the acetabulum that's sloped, and we need to make it horizontal, make it hemispherical. So now, if you want to quantify it, there was a very good paper that has tried to quantify it, and they have proven it that increasing the reamer size and deepening the cavity has significant influence on bone loss with minimal increase in contact area. So there is no need to get a bleeding medial wall. We just need 50% good bleeding bone. We remove cartilage, have bleeding at three regions, that is the ilium, ischium, and pubis, and preserve subchondral bone. And size is determined by the anterior and posterior column of the acetabulum, and not by the superior and inferior dimension. Now we have done the reaming. We put the trial. Trials are more malleable, so it's easy to put in the 51 trial. And then you remove the handle. You check whether you can remove the trial easily or not. If trial is easily movable, then you need to go one step up. You need to ream more. If trial is not movable, then you can very well put your cup. Now, with gentle movements of the lever, the trial must not move. Once you have taken the position of the trial, you make a note of the acetabular trial position, and then you aim for 35 degrees operative inclination. Now, this is a very important concept. To get a 45 degrees radiographic inclination in the postoperative X-ray, you should aim for 35 degrees operative inclination. When you aim for 35 degrees, then because of the effect of antiversion, in X-ray you will get 45 degrees of radiographic inclination. So cup is inserted at an angle lower than 35 degrees. Its inferior border is made parallel to the tell, and then it is abducted to get the desired abduction angle. Some surgeons consider cup impaction as a two-person job, but many surgeons are doing it as a one-person job. To reposition the cup, we must not lever an impactor, but rather use a slap hammer. Now, this is very
Try to
important.
Summarize.
Yes, sir. This is the last slide. If the cup is loose, then check whether there is soft tissue interposition or not. If there is no soft tissue interposition and cup is well seated, now there can be two situations: whether the cup is well seated or not well seated. If the cup is well seated and it is loose, that means we need to ream slightly more with one size less. But if the cup is not well seated, then we need to ream with the same size. So this is the tip. If in case we have opened the cup and we find it to be loose, and this is the tip to get the desired angle, this desired stability. Thank you so much, sir. So this was all about the cup stability in primary THR.
Thank you. Any questions?
We'll take an end of session.
At the end of the session.
Thank you, Dr.
Okay.
Jaman. We'll take any question later on. Thank you.
Thank you, sir.
So I'll invite the last speaker of the session, Dr. Swashish Roy. Is he here? Yeah, the topic is, please, sir. The topic is speaking on stem cell therapy in spinal cord injury. Dr. Roy, please.
No, Dr. Bera is the last one. He's not there.
Good morning, respected chairman, the members in the
Distraction.
dais, my friends, colleagues. This is a different topic from orthopedics, or rather I'll say arthritis today. But as Professor Yadav had reiterated in the first day, that every clinician or every doctor should be a scientist from his heart and mind. So I had always been uh, tried to be a scientist. I had always tried to follow up new roads, and this is one of my endeavors or our endeavors in our Spine Services India, so that we could help the spinal cord injury patients with a little bit of therapy indigenously, not copy paste from the Western literature. This is spinal cord injury. I'll not go into the details. And the different types of stem cells, what we use in our protocol is bone marrow mesenchymal stem cells. There are different clinical trials which are going on through the world are just summarized in this table. And these are the pathophysiology and the stem cells of spinal cord treatment, how they go. I just brief up that when the stem cells go, they make the layers or the oligodendrocytes, the myelin sheaths, and after the myelin sheaths are properly formed, then only the axons regenerate. Till now, there has been no definite conclusive evidence that they regenerate axons. The myelin sheaths are regenerated, and these myelin sheaths help the axons to grow. And these stem cells are a part of the natural healing process. We only accentuate the healing. We do not give something new to the body, or we do not create something new. In our case, there were 7 subjects, 5 male, 2 female, between 14 to 52 years, with a mean age of 32.71 years, standard deviation 12.09. 3 subjects had spinal cord injury in the cervical, 2 in dorsal and 2 in the lumbar levels. Causes were all traumatic. The range of intervention was between 6 to 18 months, and the reason for these were they tried different therapies. They were first going through the surgical intervention, rehabilitation, and after they consented, because stem cell therapy is a very controversial subject, and because it's a controversial subject, so it has to be discussed in full with the patient, the relatives, and they have to take also opinions from others, and that relates to the delay in therapy. 4 males and 1 females, the stem cells were harvested from bone marrow. In the earlier part of the study, 1 male and 1 female, the stem cells are harvested from peripheral blood. Nowadays, we use only bone marrow mesenchymal stem cells. These bone marrow mesenchymal stem cells has to be harvested from the PSIS, and usually they have to be introduced by a Jamshidi needle into the perisinusoidal region. The yellow bone marrow contains the maximum amount of bone marrow stem cells, while the red bone marrow contains the hemopoietic stem cells. But they can contain, but we cannot differentiate between the red bone marrow and the yellow bone marrow. So when we aspirate the full. But it has to be introduced into the perisinusoidal region, otherwise we can't get a good amount of bone marrow. It can be fluoroscopic guided or it can be ultrasound guided. So the bone marrow aspiration, filtration, and I'll now go into the process. The process is after the bone marrow is harvested, the amount of bone marrow harvest is not less than 800 to 900 ml or rather 1000 ml, which is very difficult from 1 PSIS. So we have to pick a number of places on one side, also a number of places on the other side, and we may have to go for 2 or 3 days therapy, 3 days procedure to get the required amount of bone marrow, because 1000 ml of bone marrow will give only 0.001% of mesenchymal stem cells. This bone marrow is transported by heparin tubes into we had tied up with a local blood bank. They are put into cell separators. Previously, we used the fecal park method. Nowadays, we use the cell separators. After the cell separators, the cell is separated into these layers, which is the Buffy coat stratum, mesenchymal bone marrow stem cells, and much below is the white blood cells. So these graded black lines, which contains the mesenchymal bone marrow stem cells, these are to be aspirated very carefully, which are done by the laboratory people. There was once a question raised in this platform for a previous speaker, that how do we know that these are the only bone marrows and there are no other cells in it, or these are only bone marrows or not any type or any other kind of cells. To be frank, we after we have taken out or harvested these mesenchymal bone cells, the laboratory people take it under microscope and give us a confirmation that yes, mesenchymal bone cells has been harvested. Only then we inject. And to be candid with everybody, we do not know, not the laboratory people know, there is still not any method available in this country to know whether it has been diluted with any other kind of stem cell, any other kind of cells. So what is the method of therapy now? After this, about 1 ml or 2 ml of bone marrow has come up, we segregate the patients. After having taken the ethics committee approval and the approval from the patient relatives and all, we do a spinal cord tractography of this patient. Because we do a spinal cord tractography, but we measure the void area and the level of the voids. I have not included this in my slides because of the process, because these are under patenting processing, so I can't include this in the slides. But you all know what a spinal cord tractography, those people who are dealing with spine. So spinal cord tractography delineates the void, and after that we take the patient to the OR. When we take the patient to the OR, the anesthetist puts in a epidural catheter with a 16 or 18 gauge 2-hour needle right up to that level where we had marked at that place in that MRI tractography region, that is the area of the void. This we can obviously see through a fluoroscope that it has reached that place. Once it had the tip of the epidural catheter has reached the place, then only we inject the bone marrow directly through the epidural catheter. Because the epidural catheter has a very long channel, the whole of the 1 or 2 ml will be stranded within the channel. So we use a little bit of lignocaine or bupivacaine or tramadol, whichever the anesthetist chooses, he gives to flush the bone marrow into the void area. After it has been put into the void area, the epidural catheter is taken out, it is plugged, and the process is complete. Mesenchymal stem cells. The International Society for Cellular Therapy has developed criteria to outline human mesenchymal stem cells. These are defined as those cells that are able to adhere to plastics and express a number of cell surface markers while undergoing multilineage differentiations. These are multipotent stem cells obtained from various adult tissues. Mesenchymal stem cells represent only a small fraction of non-hematopoietic multipotent cells of the bone marrow. They have developed a great attractiveness for regenerative medicine. Cultured or non-cultured, we always use non-cultured because cultured mesenchymal bone cells are very costly and are not available through our institute, which is a fledgling institute and do not have any form of sponsorship. And also cultured mesenchymal stem cells have legislative barriers. They have potential risks. There was once a paper quoted that Professor Rajshekharan had quoted in a paper that there might be malignant transformation of stem cells. I will say that I had also read that paper, and there is a Korean paper which also says that mesenchymal stem cells, I mean bone stem cells, can regenerate into malignant bone cells in rats which are cultured. They had emphasized it on cultured, but they have not said anything on non-cultured.
The last 3 minutes, sir, please wrap up.
Yeah,
Thank you.
I've done. Bone marrow concentrate is always done, finished. Transplants procedure, I've already explained. Statistical analysis, moderate correlation was found between the age of the subject and ASIA score. All of these patients had ASIA A, and we had followed them up to 3 years at least post therapy. The source of the stem cells was found to be non-significant. No significance was found regarding the separation method and the method of transplant. While age and source of harvesting of stem cells in this small sample were significant, with the end result of improvement using ASIA score and Kimura scale in NCB, mode of cell separation and mode of transplantation was not significant in the end results. In our series, all the 7 patients are now in stage D, or 2 of the patients are in Asia grade E, and other 5 are in stage Asia grade B. If possible, I'll present all my series along with a control series in the next IOACON, for which will emphasize on a study. Thank you for your kind
Thank
listening.
you.
Thank you, sir.
Any question on this paper? Well, mesenchymal cell has got a capacity to convert itself into any cell depending on the circumstances and the situation where it has been implanted. In fracture cases, the basic mesenchymal cell has got the capacity to get converted into osteoblasts and osteocytes. Similarly, it appears and it appeals also that these cells, if put into malignant tumor, it is possible what Dr. Rajashekharan has read and what you have read, that if these cells are implanted into a malignant area, it is possible that these mesenchymal cells may get converted into cancer cells. Because mesenchymal cell, the basic cell, has got a great capacity to convert itself under the circumstances in which it is placed.
Sir,
No more questions?
Sir,
Professor, there is one more talk. Okay. Please.
Sir, can I just say on your words?
Yes.
Sir, because I had already told that in our series, but we have found out that these mesenchymal cells, they differentiate into oligodendrocyte and the myelin sheaths. But in no study throughout the world, it has been shown that these mesenchymal cells develop into neuronal cells still now.
Thank you. Thank you. Yes, please go on.
So I invite the last talk, Dr. R.K.S. Dhakar. And the topic is core decompression and bone marrow aspirate in femoral head osteonecrosis. Dr. Dhakar, please. Around 8 minutes, sir. Last talk.
Respected Chairman, Co-Chairman, sir. Thank you very much, Meena, sir, to invite me. Here, see, after the replacement, I will talk about preservation. See, osteonecrosis, we all know it's a osteonecrosis and femoral head. It's a big problem, especially in younger population. Day to day, we all orthopedic surgeons, we are encountering. By definition, we all know it's a cut off blood supply in the femoral head because of various reasons. Although the multiple theories have been proposed, no pathophysiological mechanism has been identified as a etiology for the development of this osteonecrosis of the femoral head. However, the basic mechanism is just to impairment of the circulation. We know various non-operative treatment regimes have been evaluated and is still under trial, but still we are not any final result. The prospective and multi-center randomized trials are needed to evaluate the efficacy of all these regimes. The joint preserving procedures are indicated in the treatment of pre-collapse stage, because if we save the natural head, that can be saved forever. Ultimately, in case of advanced stage, a lot of studies they show for the joint replacement, they are better. So there are some proposed etiopathogenesis. Why this avascular necrosis occurs? There are various reasons, like in case of dislocation of the femoral head, in case of fracture neck of femur, or in case of acetabular fractures. But out of these, most of the avascular necrosis patients coming because of steroid, either for the therapeutic use or maybe because of either some patients, as I encountered in my practice since last 20 years, most of the young population is coming. When we inquire about the history, they are somewhere talking about the drugs they taken either for to build the body or to have a good look. And there are some other disease and some therapies they may also associated with this avascular necrosis. We all know about the various classification system. So before deciding the treatment regime, we have to classify according to the FICET, we know, but in stage 1, it's absolutely normal X-ray. But with the clinical ground, if we ask the patient for MR, then only it can be diagnosed. So these are the various stages. So stage 1 and 2 can be saved. Another ARCO system of classification, it also tells about the different stages, and we can decide which stage can be salvageable. So there are current concept review of non-traumatic osteonecrosis of the femoral head. Now where we do stand. So various studies, they show for the treatment options like non-operative, just observation, and there are some different treatment protocols just to save the femoral head. In operative category, it's a well-established procedure like core decompression. So different type of drilling and along with the bone marrow injection. So this is a stage. If this patient comes to the orthopedic surgeon, always first thinking comes in mind for the replacement. Always orthopedic surgeon smiles. Come, I will replace. But before thinking about the replacement, if head is salvageable, then we should think to preserve the natural things. How this proceed? Initially, you can see it's just a lysis behind the cartilage. This is the stage that can be saved. And if we leave it as such, then ultimately it progress to the advanced stage. So there are various studies, they show the use of bone marrow injection in the treatment of this avascular necrosis. The Journal of Bone and Joint in 2005, they published the safety of autologous bone marrow transplantation. The many surgeons now use bone marrow because of its biological value and low risk. Another study show it's a significant reduce in the pain and the disease progression at the 5-year follow-up. The Journal of Orthopaedic also published the installation of the bone marrow derived mononuclear cells concentrate into the core tract. The bone marrow stem cell injection with the core decompression can be effective in early osteonecrosis of the femoral head. So this is to be decided whether fractionated or unfractionated. So what I did, I use unfractionated bone marrow in the avascular necrosis of stage 1 and 2. Why I prefer? Because this is well supported in the literature. It do not require any fancy equipments. It's very cost effective and less time consuming. Minimally invasive, patient can be discharged the next day. How this bone marrow acts, as Yadav sir mentioned, this bone marrow contains mesenchymal cells. So they promote neoangiogenesis, they promote neoosteogenesis and also osteoconduction. I personally did some cases. I'm using this since last 5-6 years. So this was the case initially came to me. X-ray showing not much collapse, but MR shows. So this is a very simple procedure. I have a guide wire in the targeted area and using DHS triple reamer, ream the targeted area, and with the same track, I'm little bit different. With the long drill, there are some multiple drills in that area that can remove some dead bone and also create some some holes in that area. This is the procedure. And immediately aspirate a 20 ml of bone marrow from the iliac crest and infuse without delay. Very simple. So there are some other cases. It's a 50-year male working with High Court came to me after consulting with the neurosurgeon, get an MRI, treated for some months, again went to some orthopedic surgeons. MRI knee was done. Nobody was thinking about the hip. When he came to me, I went through the X-ray and MRI bilateral hip. MRI shows a clear-cut involvement of the anterosuperior portion of the head of the femur. Drilled and bone marrow injected. This is down to 3 years. This patient is nicely working and don't have any the pain.
The last 2 minutes, sir.
Sure.
Thank you.
So there are some other cases also. So post-operative protocol, we ask the patient to have some crutches for walking. So my motto or my thinking is that if we can save 1 out of 10, it means we can save forever. Or if we can delay the joint replacement for 5 years or 10 years, I think it's a good for a patient. So take home message, it's a procedure
to preserve the natural gift of God. It's non-expensive, easy to do. It's a care procedure, but more research to be needed how this bone marrow is working. So this is a difference between the natural and artificial. So thank you very much.
Thank you, sir.
Thank you, Doctor. Dr. Tuli desires to speak for not more than 2 minutes particularly to the postgraduate students on this session. 2 minutes only, please.
My young friends have heard the story around the stem cells. All of us use stem cells. Whenever you are doing a grafting, what is working? One of the important structure or cell which works are the stem cells. But please remember, I'm talking to the students. The senior people probably know much more than what I'm talking, or much more than what I know. But my younger friends should know, we will keep on talking about stem cell, but the stem cell will get modified by the influence of inductor. What provides inductor? The recipient bed. Where are you placing it? It's the recipient bed which is going to convert that stem cell to blood cells, blood vessels, bone, cartilage. If you are poor, if the environment is poor, fibrosis. So this is what the stem cell has the potential, but you have to provide him the environment. Stem cell has produced almost many organs, but it has not been successful in making the neuronal cells of the brain and the spinal cord. These two areas, stem cell has failed. Why stem cell can convert into malignancy? Again, depends upon the environment provided by the recipient area to that stem cell. I think it's good that some people did mention about the statement of the malignant transformation. It did happen. It happened even after a dose of locally placed BMPs. It happened in a spinal case in America. It was nothing wrong with the BMP, nothing wrong with the stem cell. Something was wrong with the recipient area. The recipient area induced these stem cells to belong malignant cells. So this is the story of stem cells. Love them, think about them, use them.
Thank you. Thank you very much. Well, that brings this session to an end, and we hand over the mic to the organizers. Thank you. Thank you very much.
So there is 2-minute interlude. Then we are starting the valedictorian ceremony shortly, 5 minutes, sir. So stay with us, stay tuned, and please stay in hall. This is a penultimate event and one of the key event of IOA, the change of guard, change of jewel. Upcoming generation being handed over the guard by the past incoming generation. अभी है ना आगे बोलो हाँ देखिए हाँ. Yes, sir. So, very good morning, ladies and gentlemen, beautiful ladies and dashing gentlemen, all here for the penalty mate event. The gonna be glittering function of President Mini Icon, that is change of guard, valedictory function of IOA. So, to start the proceeding, may I request our dynamic organizing chairman come president IOA 2020, Dr. R.C. Meena, to please come on dais and have a seat. You are the first, sir. Diligently trying to follow the protocol. If some human error happens, so I beg an apology. My salary has been kept hold so many times. I'm used to it. We are bureaucrats. We survive in every government. So now, may I request our coming president IOA 2021, Dr. P. Shivashankar, a dynamic surgeon, wonderful academician, and having said that, I must emphasize this is he's a true gentleman, a gentleman of orthopedics, like we have Stephen Edberg in lawn tennis, like we have Roger Federer, gentleman of orthopedics. Everybody cannot claim that he's a true gentleman. I have interacted with him for years, and we're gonna see more of him. And now I would my salary is already on hold. I might withdraw. I might withdraw my statement. But all I am trying to do justice to whatever I have seen, whatever I have observed of the pupil. You have already told me that I am a keen observer. Now I would request our Secretary General till date or till 2020 and our Vice President, give him big hand, Dr. Atul Srivastava. When he will hold office in 2023, I bet that he would be one of the youngest. Older senior Srivastava, I have no longer memories. I was too young then, but I can bet his youngest vice president will be the youngest president. Now I would request our honorary secretary, coming honorary secretary, Dr. Naveen C. Thakkar, a staunch academician, an staunch organizational man, a wonderful orator, wonderful speaker, and accessible easily every day, day in, day out. Now I would invite our coming joint secretary, Dr. Pradeep Bagecha, consultant from Gangaram. Give him big hands. He's ready to. Now I would request our joint secretary till date and coming treasurer of IOA, Dr. Sandeep Kumar, my senior and consultant in Jamia Hamdard University, a treasurer, so probably more important person for me than others because he's gonna do an audit. And then thereafter, I would, thus this quorum is complete. Now I would request Dr. Atul to
You've been listening to Arun since the last 3 days, and he's been conducting the Hall A. Conducting the Hall A singularly is a task in itself. And congratulations, Arun, I would like to take your seat as the organizing secretary of the Mini IOACON 2020.
Thank you, sir. Thanks a lot.
Dear friends, thanks once again that all you are here and being with me in this difficult and such crucial period where nobody want to come out from the house, but you are out of the house and with me in this audience hall. I request one by one from the all 5 zones to say and give their feedback and observation about this conference, whatever their feelings, so that we can improve our next conference or correct if any shortcoming has been left. So first I call from the central zone, Dr. Saket from central zone. Because Dr. K.D. Tewari and Akhilesh has left hall, their flight
Saket,
was
you can
at 12.
speak from there. You have a mic there.
Thank you, Meena sir. It has been a privileged pleasure to be here in Mini IOACON 2020 at Jaipur. After having had a tough time from March 2020 till date, I believe it has been a wonderful and very personalizedly organized conference where most of the people, orthopedic surgeons who have come here, they have so much of positive vibes. I believe this is remarkable. And thanks a lot to the team of Dr. R.C. Meena sir and Dr. Arun Sharma. And heartiest congratulations to the President, Dr. Shivashankar, Secretary, Dr. Naveen Thakkar, the Vice President, Dr. Atul Srivastava, the Treasurer, Dr. Sandeep Kumar, and the Joint Secretary, Dr. Pradeep Bagecha. I convey the gratitude to the organizing committee and IOA officials on behalf of Central Zone. Long live IOA. Thank you so much.
Thank you very much, Saket. So nice of you, my friend. Now, representative of the East Zone, Dr. M. Emre, sir. Dr. Parth. Yes, sir.
Yeah.
MM, sir.
मैं क्या बोलूं? Professor Meena, Dr. Arun Sharma, and the IOAC dignitaries, Dr. Atul Srivastava, Dr. Naveen Thakkar, and Treasurer Sandeep Kumar, and Dr. Simply, I could not imagine that such a mini conference could be held. I had the information before, but when there are a lot of oppositions, and I found simply it cannot be done. So I gave up the hope that it is not possible to attend this conference. But however, whenever I contacted organizers, they said, Arun particularly, and Professor Meena sir, yes, it will be done so easily. So I had to have the ticket. Just at the last moment, I purchased the ticket and got it. And I find this is a unique one. And in even the odd time, in this pandemic situation, they have done it, and it is materialized and fine. And I find a lot of interested people, even our Professor Tuli has come here, and a lot of from Mumbai and others. I really salute the organizers for such a brilliant conference. Thank you.
Thank you very much, sir. Ray, sir, we impressed with your kind words. And now I request from the South, Dr. Mallikarjun, sir.
Thank you, sir, for giving the opportunity to express my views. Dignitaries on the dais and off the dais. I can tell you the story of Mini IOACON, how it happened. It happened because of the grit and affections and positive mind made this conference to happen, actually. And of course, whenever we attend the EC meeting of IOA, we are all positive mind people. It definitely should happen. And a couple of times I discussed with President R.C. Meena and incoming my friend B. Shivashankar also. We are all positive, actually, to attend this. but within a short time, short notice, you have conducted a beautiful conference. I think it is one of the wonderful things you have taken in a positive way. I think I congratulate on behalf of South Zone. Thank you, sir. Thank you very much. Long live IOA.
Thank you very much, sir. So nice of you. I request Dr. Tuli, sir, as a representative, of course, your stature is much higher than the zone. You are the symbol of the whole ION country of the fine brain orthopedicians. But I request you as a North Zone representative, please give your valuable words.
The
and
way you are making me come to the speaking area, probably you are spoiling me. That's my feeling, that you are spoiling my habits. Probably difficult to spoil at this age. Everything is fixed already.
Thank you.
My friends, as our association provides us an opportunity to listen to the work being done in the country. Same problem, multiple solutions. That's the beauty to listen to. A disease of the hip joint can be treated by operation, remove the bone away, or reconstruct the bone. So all this one can see, there are so many methods of treating the same condition, and that is what you learn sitting in an organization like this. These associations and meetings, they do serve the academic purpose, but they also serve the social purpose. We are social animals. We are human animals, but we are fortunately social animals. We also learn how to tolerate each other. Somebody has a different way of expression, the other person has a different way of expression. We learn how to tolerate all this. We are a part of a huge family with multiple generations. Developing generation, developed generation, and probably the super senior generation. Let's learn to live with each other, interact with each other, look at each other, recognize each other, and maintain a large social family and a large familial feeling and a get together. I wish all this is continued for future years. The organizers have served to provide all these facilities in this conference. Probably I have been overexposed in this conference, though I'm a backbench sitter, but today, this conference I have been sitting all the time in the front line. Thank you very much.
Thank you very much, sir.
Professor Meena.
So
Thank
nice of you for your kind words. I request Dr. Kanabar from the West Zone. Of course, his stature is much higher than the West Zone, but today we have an opportunity to listen something from him for this conference as representative of West Zone.
Good morning, Professor Meena, Dr. Shiva, all the dignitaries on the dais and my friends over here. Something will happen, will not happen, went on happening for a long time in IOA. It's a very sad year that we had pandemic from March. And probably the academic activity in person completely stopped. We had webinars and we had talks digital, but whatever happens together and what sir mentioned about social, that is which is very important, and that is what could happen. So I would like to thank Professor Meena and his team and all the executive committee member of 2020 who agreed upon to have this meeting, IOACON, and it has happened wonderfully. Sir, you have done everything, all academics, they were there, all socials were there, wonderful evenings were there, get together was there, and this was something what any orthopedic surgeon wishes to attend to. I'm very happy I came here. I'm very happy you did this conference, and it is done in a wonderful way. I want to congratulate you, Professor Meena, and your team, Arun, everybody. You have done a wonderful job. Thank you so much.
Thank you very
I
much,
really
sir.
appreciate it.
Thank you, so nice officer. And a representative from the Naroza, Dr. Satyajit.
Respected Meena sir, Siva Shankar sir, Atul Srivastava and Naveen Thakkar and everybody in the dais. At one time, we never thought of this conference, and I feel really proud that the IO has gone forward to organize this event in this difficult time. This pandemic has changed our social attitude and behavior, which is obvious everywhere. But in spite of that, I really congratulate Meena sir and his team for nicely organizing this event. Though it is termed as a mini IOCON, except for the smaller gathering, we have never felt it is not like an IOCON everywhere. It's good socialization and good academics also, excellent academics. Though number of halls may not be 6, 7 halls, we are having in 4 halls, but it's excellent academics, sir. I must admit, and definitely we enjoyed it. And my greetings to everyone from Northeast. And I especially am lucky to see people like Professor Tuli sir, Kanabar sir, Yadav sir, in this difficult times amongst us. Sir, wish you all good health and future. Keep blessing this IOA and IOA members in future like this, sir. Thank you so much.
Thank you very much, Satyajit. Now in the last, I request Dr. S.S. Yadav, sir, as an expert opinion and blessings on the behalf of past president for this conference. Sir, please say what is your feeling.
Dignitaries on the dais, my colleagues, young orthopedic surgeons. I'm very happy to be here for the last 3 days to enjoy this great get-together. Conferences, ordinary conferences, usual conferences are held every year towards the end of the year. But this year, as you know, unfortunately, we had COVID-19 from March, and the whole year was passed in a sense of instability. Instability, I use the word because there was a sense of negativity. There was a sense of negativity throughout the year, whether the IOA conference will take place or not. And in the beginning, majority of the people wanted that it should not be held. It was considered, reconsidered, and again considered that some sort of a meeting should be held. Why some sort of a meeting when we can well call it a IOA meeting? Some of the colleagues said it should be named as CME. Why? Why degrade IOA? I could not understand why degrade IOA and why call it a CME or any other ROSA conference. No, it should be called as IOA conference. And final outcome after various meetings and meetings and meetings that a mini conference should be held in Jaipur. And let me pat the back of Dr. R.C. Meena and his team, Atul Sharma, a dynamic trainee of Dr. Meena, who is coming up, and you will see him coming up in a couple of years. He will be occupying the central chair. So give him a clap. Yes. So finally, it was decided that a mini conference should be held in Jaipur. Ladies and gentlemen, it was a task to hold the meeting in 3 months' time or 2 months' time. Till the last moment, Dr. Meena did not know whether the conference is going to be held or not, be it a court case, be it the circumstances under which we were working. But finally, it was finalized that the conference shall be held. And as various people have expressed their views before me, that it should be rated, it will be rated as one of the best conferences of the recent times. And the credit goes to Dr. Meena and Dr. Sharma. I must appreciate the support of Dr. Shiv Shankar, who always said, yes, sir, we can hold the conference. We can hold the conference. And I must appreciate dear Atul's efforts from Agra that the conference was finally recognized and to be tabulated towards the end of the year. And it is one of the best conferences to be remembered. Last, I would like to appreciate and thank the ladies of these great people in Jaipur who have spared their husbands to work day and night to make this conference a great success. I do not know if Mrs. Meena is there in the crowd, but I will request Dr. Meena officially to thank Mrs. Meena and all other members of the team to thank their wives who have spared their great husbands to make this conference, to work day and night to make this conference a great success. I think I have no other words to say that, ladies and gentlemen, it is done. A very important point, which I have been saying in the meetings also, and I'm happy that the organizers had taken that point, that 65th number would have been missing from the armamentaria of the IOA if this meeting was not held. Tomorrow, after 10 years, 15 years, when the youngsters will count 1, 2, 3, 4, 63, 64, 65 किधर है? 66 बॉम्बे, 65 नहीं है. कम से कम अब इसके बाद 65 नंबर आ गया है. That 65th conference was held in Jaipur and with great vigor. Thank you very much.
Thank you very much, sir. As you told, no word, but the whole house knows that you are the dictionary of many fine words. And it is very difficult to select the fine among us, the fine, and that you have done wonderfully. So nice of you. So now I take opportunity to give my summary of tenure with the permission of the dais and the house and dignitaries on the front. Mike, yes. So good morning, the friends in the house. Dr. Shiv Shankar, President, IOA, IOACON 2021. Vice President, Dr. Atul, Secretary, Dr. Naveen Thakkar, Treasurer and past Zone Secretary, Dr. Sandeep, Dr. Pradeep, my friend Arun, and the three Dev, Brahma, Vishnu, Mahesh sitting in the front of the row. Many seniors, my senior friend, Dr. Sinde, Dr. Swami, Dr. R.C. Bansibal, Dr. Daima, and industry's colleague as well. Friends, I started to work as a part of president since past vice president, president-elect, and as a full president in the year 2017. Elected in 2017. And till that, I did my try best to serve the IOA and give the best honor to the IOA in different capacities. If you see at my personal level, I collected 15 to 20 lakhs in the year 2018 for the IOS services as a personal capacity. Again in the year 2019, 15 lakh, and in this year of difficult period, 20 lakh, 15 from the IPCA, 3,000 from other agencies. And similarly, whenever the physical meetings were not possible, I started IOA PG teaching program so that the new words and the new generation can be benefited. And all the members, those who could not join the meeting physically on the initial March, I joined it on the online 19th July 2020. In that meeting, the whole house unanimously gave me mandate to continue as the president up to the end of the 2021. But as the corona is an endless problem, we cannot predict what another corona may come. And to uphold the value and the image of our constitution and association, I decided on the 11th December to organize a IOACON at Jaipur so that all constitutional formalities can be done with the orations, official valedictory function, and for that, unanimously more than 80-90% CWC, CSRC members gave consent on the WhatsApp group. That is a valid information. What some people again object that this is not a physical meeting, this is not a real mandate. In that, दिमाग में ख्याल आया, पलट देते हैं हम मौजे हवादिस, पलट देते हैं हम मौजे हवादिस अपनी जुर्रत से कि हमने आंधियों से भी चिराग अक्सर जलाए हैं। इसके बाद में लोगों से पूछा, भाई चाहते क्या हैं आप? व्हाट्सएप पे मैसेज छोड़ देते हैं कि डॉक्टर मीना गैर कानूनी रूप से कॉन्फ्रेंस करना चाह रहे हैं, उसको तो आप सराह देते हैं, देख लेते हैं, लेकिन जब कानूनी रूप से आपके 76 आदमियों ने, मेंबरांस ने कंसेंट दी, कॉन्फ्रेंस कराई है, उसको लोगों ने माना नहीं। कोई बात नहीं, फिर भी हमने आंधियों में चिराग जला करके डॉक्टर शिवशंकर ने कहा कि हम एक गूगल सर्वे कर लेते हैं। यू वॉन्ट बिलीव फ्रेंड, 95% persons out of total survey, only 3 went against this conference, only 3. Again the question raised, sir, how it can be possible? Google survey is not valid and it is nowhere mentioned in the constitution, but they do not think. Intelligent persons say that glass is half full of water, but the sick mind person say that it is half empty from the water. It is their own problem. Anyway, then we decided to have a AGM to get the consent for this conference again. And in that conference, how so many numbers it joined? The again 90% persons gave yes, this conference held to be at Jaipur in a proper protocol and manner. And ultimately, we come to organize this conference. So दोस्तों, मुझे वो महाराणा प्रताप वाली एक कविता याद आती है, हूँ लड़ो घण्यो हूँ अड़ो घण्यो, राजस्थानी है ये, हूँ लड़ो घण्यो हूँ अड़ो घण्यो, मेवाड़ी मान बचावण ने, पर लाज नहीं राखी रण ने, बेरारे खून बहावण ने। महाराणा प्रताप ने, आपको सब जानते हैं, वो वीर शिरोमणि राजस्थान के सितारे थे कि उन्होंने अपने देश की आन बान मान शान बचाने के लिए पूरी जिंदगी में हर तरह के कष्ट सहे, और उससे कम कष्ट मैंने भी साल भर एसोसिएशन को मेंटेन करने में नहीं सहे। अगर आप देखें तो आप डे टू डे की लाइफ में देखते होंगे कि मैं 10 कदम चलता 2 कदम चलता, लोग पीछे से कोई पैंट पे पकड़ लेता, कोई जूते चप्पल पकड़ लेता, कोई कोट पकड़ लेता और 10 कदम पीछे ले जाता। इस हालात में मैंने किस तरह से इस मुकम्मल प्रोग्राम को अंजाम दिया। लेकिन हमारी एक बहुत अच्छी एक किताब है, उसको लोग महापुराण भी कहते हैं, जिसको गीता कहते हैं। उसमें लिखा हुआ है, उद्यमेन ही सिद्धायन्ति, उद्यमेन ही सिद्धायन्ति कार्यानीन मनोरथे। यदि आप उद्यम करते हैं, कार्य करते हैं, आपका अवश्य सफल होगा, आपका मनोरथ पूरा होगा, ईश्वर आपको जरूर सफलता देगा। इसी तरह से अगर आप जरा सा भी हौसला रखते हैं, निगाहों में मंजिल हो, गिरे और गिरकर संभलते रहो। हवाओं ने कोशिश भी की थी, मगर चिराग आंधियों में भी जलाकर हमने दिखा दिए। थैंक यू वेरी मच दोस्तों, आप लोगों ने मेरा साथ दिया। इन द लास्ट मैं कहना चाहूंगा कि इस डिफिकल्ट पीरियड में, जहां पर कि मैंने रजिस्ट्रेशन फीस आपसे 5,000-6,000 के बीच में रखी थी, इस होटल का एक खाना 1,800 रुपए का पड़ता है। लेकिन मेरे इंडस्ट्रीज कुलीग जिन्होंने ये आंख मीच करके, कितने लोग आएंगे, कहां से आएंगे, आएंगे भी या नहीं आएंगे, आंख मीच करके ये कह दिया, among them few I enumerate to name, that one is IPCA Pharma, Trioco Pharma, Tyanor Orthotics, Ellinger, MacLeod, Alchem, Omnicorus, Zydus, and many more are there. I'm sorry not able to take the name because these are a big list. But again, I was shocked to see in the last, sir, that many nefarious persons write letter to the bank, don't open this account, this is illegal conference, and the bank manager passed that letter to me on a mail, and he write in the footstep that, sir, don't disclose my name, it is very confidential and very financial. And not only he write to the manager of the bank, he write to the all top GM of that bank. And he started a series of the letters and the mails daily to all dear industries, colleague, friends. See the version of our president that this conference is not constitutional. Don't participate. Think twice before participate in this conference. But thanks to my industrial colleagues, they send all these papers in the dustbin and ask the sweeper that don't sell them at the rate of 10 rupee per kg as a raddi paper. Rather, he said dump them so that they doesn't come in front of the next coming president or leader of this association to malign the image and disturb unnecessarily those who want to do something for this association. Thank you very much, friend. Have a nice day. And my faculty, Dr. Daima, Dr. Bansiwal, Dr. Arun, Dr. Abhay, in my absence, Dr. Rajan took my charge of my unit, worked day and night 24/7. Okay. Yes, Narang Sahib.
Good morning, everybody. I'm R.K. Narang from Elangers. I could not resist coming on the stage or just to say a few words because I heard everybody saying about the conference and I wanted to put a few words from our organization and on behalf of the trade industry. Sir has already named the participants of the industry. I just wanted to add that I heard the Central Zone, North Zone, West Zone, South Zone, all of them have said adequate words that yes, this conference deserves a big clap. Please clap. And I, on behalf of the industry, would definitely say that we had full trust in Dr. Meena.
Thank you very much, Narang
Whatever
sir.
he said just now It's a true fact that we have received such WhatsApps also, but we did not care for it because we trusted it, and we are very happy that we have participated and lived up to the trust of Dr. Meena.
Thank you very much, sir. Narayan sir. Thank you very much, sir. On a single call he came, not repeated call. Just I called Narang. Yes, sir, we are with you. Thank you very much, sir.
So sir, let the exchange of jewel happen. This was the key event of this conference. So ladies and gentlemen, we are here for this final moment of the final event. This is the exchange of jewel and change of guard ceremony of Mini IOACON 2020 65th Indian Orthopedic Association meeting. And we are no need of introduction, but we are introducing our new dynamic, humble, jubilant Dr. V. Sivasankar. It takes a lifetime to become a president. When Manchester United introduce Paul Pogba or any football player, they make a conference, they make a hue and cry. Then why can't we organize it?
Congratulations, congratulations, congratulations.
This is the proper event. This is the proper way. It takes a lifetime to become a president. And not everybody is so lucky to become the esteemed president of this 30,000 plus members fraternity, which is rubbing shoulder with best of the best, AAOS, BOS, everywhere they are. So, sir, I guess
coming to that, there is also an outgoing president's medallion. I would request Dr. Shiva Shankar, President IOA 2021, to hand over the outgoing president's medallion to Professor R.C. Meena, President 2020.
so first time from the Rajasthan, we had a president. From the land of Sanghas or Ranas, we have finally a president. Now I invite the new president of Indian Orthopaedic Association, Dr. Shiva Shankar, to share his plan for future. Sir.
Immediate past president, my elder brother, Dr. R.C. Meena. Vice president, immediate past press secretary, Dr. Atul. Incoming secretary, Naveen. Incoming joint secretary, Pradeep. Incoming treasurer, Dr. Sandeep Kumar. Organizing secretary, the name I gave yesterday to my friend Arun. Senior sitting in the hall, past president, Professor Dr. Tuli, Dr. S.S. Yadav, Dr. Kanabar. Ladies and gentlemen, friends, it's customary for the new president to give a theme in the last decade. It was not there before 2011. If I am right, Dr. Rajshekharan started giving a theme. This time, I am changing a bit. I am not only giving a theme, but I am also giving a logo for the year 2021. My presidential theme for the IOA for the year 2021 will be Please welcome my presidential team. It's Atmanirbhar Orthopaedics, Indian at heart, global in competence. It's Atmanirbhar Orthopaedics, Indian at heart, but our skills should be global and second to none. Coming to the theme, Atmanirbhar Orthopaedics, that's the first part, and the second part is Indian at heart and global in competence. As I said, I have a logo as well as a theme. Let me come to the first part of the theme, that is Atmanirbhar Orthopaedics. It represents that we are self-sufficient as far as orthopedic as a whole is concerned. We are Atmanirbhar in every aspect of orthopedics. We train our young surgeons in such a way that they need not have to go abroad to acquire skills. We have a lot of knowledge in our own country, but unfortunately, we don't have a systematic way of training our young people. So that's one of the area where I want you all to work. We all know, or you all know, that we do get medical tourism patients from abroad or across the globe. Our standard of treatment and patient care doesn't require to be talked in front of you. So we are Atmanirbhar in that respect. Unfortunately, our young generation keep going out for training because we don't have a structured training program in India. And also the stipend they get is meager. So they better go elsewhere where they get better stipend. That's one of the reasons. So that we have to work on that. My wish is also that we should also become not only Atmanirbhar in soft surgical skills like the orthopedic surgery, but also in hardware related with our practice, like the instruments, implants, CM machines, machinery required, implants we are using. Everything should be of global standard and it should be available. We have many Indian companies, they supply to the world. They have CE certified, FDA, US FDA certified implant. They are manufactured in India. Unfortunately, they are not available to us. So I request all of you to be Indian, buy Indian, and promote Indian. Yes, we should not compromise on the quality, friends. Just because to save a few $100, we should not use a substandard implant. Only if we promote good quality implant and start purchasing them, then only this our trade partner will also improve. Instead of only supplying it to the world, they also will start supplying to us. Coming to the next part, Indian at heart, that's the first part of the second part. Global incompetence is the second part. What is Indian at heart? Friends, you all know, yesterday Dr. Yadav was telling, for tibial and fibular hemimelia, BK amputation is not the treatment of choice which is recommended by AAOS. Our Indian patient refused that treatment of amputation and a prosthesis. That's the standard protocol there. Our customs are different. Our requirements are different. Our faiths are different. Our culture is different. If I advocate for a fibular hemimelia or tibialia amputation, if there is a sensation in the foot, none of our patients take that as an option. Also, India is a unique country where treatment is decided not only by the protocols, but also by the economy. If an elderly patient in the family has a hip fracture, the son or daughter thinks, is it worth spending ₹1 lakh to get him operated or let him die? They save money for marriage, but they'll never save money for medical treatment. When you go to a shop, we buy a mobile, we give ₹50,000, but in my hand, I can come and show I have got a mobile. But if they come to my hospital with a fracture, can they go out and show off their fracture? I had a very bad fracture, it has been fixed. Nothing they will get. That is the problem we have in India. So that has to be taken care. So our heart should beat for the benefit of our patients and our society. We, as I said, have a unique problem. We should have empathy for our patients, and we should take decision in the best interest of our patient, considering their socio-economic and cultural aspects too. This is what I want to, by meaning Indian at heart. Coming to global incompetence, as I said earlier, we are second to none. We are one of the best because we do get complicated cases. Our skill as orthopedic surgeons should be second to none. We should learn and implement newer technologies, and we should always be ahead of time. Experts should impart good training to young aspirants. The young trainees should also get assured amount of as a stipend. That is one of the main reasons, because medical education goes beyond 30 years of life. How many days our young generation can sustain with a family with such a paltry amount as a resident he gets? So we should also increase our stipend, which are commensurate with the age and experience. India should be the preferred destination for medical tourism, as I said earlier. Coming to the theme, what this theme has. There is a hand which covers and protects the IOA logo. We are one family under the banner of IOA. That's what the hand says. We shall protect the interests of our members first. We shall work for the benefit of our members first. There is another hand which supports the Indian Orthopaedic logo. This logo, this hand says, we care for IOA. We want to support IOA. Our motto as members of IOA is to serve the patients with proper care and empathy, and to give a healing touch to our patients. Lastly, there is a tricolor in the background, the Atmanirbhar India logo. Tricolor in the background says, I am proud to be Indian. Mera Bharat Mahan hai. We are proud to be a member of Indian Orthopaedic Association. We shall give due credits to our own Indian studies done by our own friends. We all quote foreign references when we give our talk. Why can't we quote our own papers? We have the greatest of the tuberculosis person sitting in front of us. Middle path regime has been given to the world by Dr. Professor Tuli. Fibula graft has been given to the world by Dr. Yadav. Dr. Kanavar is the first person in India to do the arthroscopic surgery and teach so many people how to do on an Indian patient. We have such stalwart sitting. Why we should be quoting something else? Why can't we quote Ganga Hospital score? Why we should only quote Gustilo Anderson score? We have so many studies done by us. Unfortunately, we ourselves don't quote our people. That should stop. We should proudly acknowledge the innovations done by our own colleagues. We shall project IOA in a global platform in a better way. We want to promote more indigenization in orthopedics, especially in implants and instrumentation, to cut the cost. We all proudly say that I only use imported implant. I never use Indian implant. That should stop. Friends, 99.9% of my implants are Indian implants I've been using. If I use any imported, it's only replacement surgeries. I want there also to use an Indian implant. Unless we promote our own companies, they will not come with a good quality implant. The people who do it in large numbers should promote such companies. They should be used properly. We want to promote more indigenization in orthopedics. India should be most prepared medical destination for medical tourism as far as orthopedic is concerned. Coming to my vision for IOA, there is nothing new. Whatever I had done 3 years back as my vision for IOA, I have not changed even a word from that to enhance membership. Friends, that's the reason why we have given a chance for all to become member before 31st of March, so that you will be ratified and you will be able to vote in the next election. My vision for the young orthopedic surgeons: institutional subscription of JBJS, ACTA, and other major journals, and with all archives can be accessed to all the institution will be to be supplied from IOA side. To increase the create pool of various fellowship and jobs available to coordinate through IOA. chart out path, including minimum stipend to be paid. Because I do get so many young people asking, sir, I want to do this fellowship, where I can go, how much I am going to get. So many messages I keep getting. Friends, Dr. Ram Prabhu started this very good program, your mentorship program. I want to continue with that program, which is very, very useful to train our next generation. Because there is something which is, when I am senior and I require orthopedic treatment, I require to be treated by a good surgeon. That's the reason why I want to train our young surgeons so that we will be in the best hands when we require them. The next one is to enhance skills and academics through virtual classes, and also to help members to publish their data in reputed journals. Already we have started doing this. In the Corona time, we have published a lot of data from India to promote research in day-to-day medical practice by organizing various workshops all over India. We shall have workshops on this topic of writing papers and research all over India. Friends, as I said earlier, during Corona time, we have conducted so many webinars. I myself conducted as a moderator more than 50 webinars. There is a lot of pool of data available, and that can be used without any problem by any member at any time. They are all available on our IOA website already. Friends, the next one is austerity drive. Money saved is money earned. To curtail unnecessary expenses on various meetings and day-to-day running of the office. Friends, we had last month only EC meeting on the Zoom and EC meeting GBM on the Zoom. What has costed this to IOA? Only few thousand rupees to get the Zoom license, that's all. And we have got that license. Now with the same license, we can do so many academic activities as well as the meetings. So I propose to have EC meetings on digital platforms so that both unnecessary travel time of our attendees as well as money for the IOA can be saved. I also propose to have a financial committee to help the treasurer, because there is a lot of transaction happens. Everything should be transparent and nobody should point a finger to our treasurer. So I want to have a committee to give a check or put a break on the expenditure of IOA also. We plan to have just working lunch during IOACON. With your support, it can be a great success, because I know so many people have tried in the past, but never it was accepted by the organizing secretary. I have already told this to next IOACON organizing secretary, Dr. Ram Chedda, to try working IOACON from 8 to 2 in the morning only. At 2 o'clock with lunch, it will finish, so that evening you are free to move around and do whatever the activity you can want to do. Let's hope that we'll see the light of the day in this coming conference. Friends, I cannot spell success without you. I request you to support this. Money can be saved. Money saved can be utilized for training a program of fellowships of our younger generations. So let's have this austerity drive. This is not new, I am talking. These number 6 and number 7 points are the same. What my vision was there 3 years back. I have not changed even a single word from them. These are all my long-term visions, which I have been thinking over and I have been talking. Friends, ask what you can do for IOA rather than what IOA can do for me. I know only about 30 to 35% of orthopedic surgeons in India are IOA members. There is a large number of people are still can be made members, and our membership from 15,000 will reach in no time 30 to 40,000 if everyone becomes IOA members. Even small step will go a long way. After all, vast expanse of water in the ocean is always formed by drops and drops coming together. Friends, charity begins at home. When I'm asking you for austerity drive and curtail expenditure, I will tell for the first time I'm announcing, in the last 2 years, I have traveled to IOA office not less than 20 times. I had to conduct the election last year. I went to IOA office, came back. I have not even charged 1 paise to IOA so far. I have paid from my pocket all this time. I always make sure that I combine some conference with IOA visit so that Even it will not pinch me as far as possible. Few occasions I had to pay from my pocket. But when somebody calls for conference, I used to include Delhi visit in my itinerary. That's how I have not even claimed. If Ramesh Pandey would have been there, he would have said, agreed with me today. Not even charge 1 paisa. You all know I updated the web data of all the IOA members. I don't know how much I have spent, but I hosted a website. Person worked continuously for 3 months to update all the data. The bill I have not given to IOA. Why I am telling is, if I don't give the bill to IOA, somebody should not think that there is something ulterior intention behind me, what has happened in the recent election. The election officer paid from his pocket because he didn't want to IOA know who are the election vendors. But that has been taken in the court of law against him, saying that why he had to spend from his pocket. Friends, we love IOA. I've come here to sit as a president. Yes, it's a hard work of 20 years or 25 years. It's not overnight I'm coming and sitting here. I have a dream, but I have to spend some little also. It's not that I have to come only to enjoy the benefits. I have to give. That's the reason why I say charity begins at home. I request all my executive committee members to help me in curtailing the expenditure of IOA by having meetings on the Zoom. The next one is IOA Social Security Scheme and group insurance. Already I am in contact with few insurance agents. They are ready to give large percentage of benefit to us. What a normal cost about 20,000, they are ready to give it around 5,000 if there are minimum 1,000 members. Unfortunately, Dr. Raj Gopalan tried about 5 years back. He was unable to succeed even to get 50 members. So again, let it be a futile one, but I want to try this for the benefit of our members. There should be a white paper on undergraduate and postgraduate curriculum in orthopedic surgery. Friends, how many days in MBBS level orthopedic is a part of general surgery? Nobody gives credit. But orthopedic surgery is the commonest problem. Accident happens day in and day out. Orthopedic surgery should be learned at the MBBS level properly. First aid should be, how to give a first aid should be learned properly. So this is also one of my area of working to have a white paper on the curriculum of postgraduates and undergraduates. As you all know, postgraduates from different colleges have different level of knowledge because of the way of their teaching. The last one is to have conference committee to allot dates so that various national level CMAs and conferences will not clash. South India OASIS have done a beautiful work. First week is Pondicherry, second week is Tamil Nadu, third week is Karnataka, fourth week is Telangana, fifth week is Andhra Pradesh. So seventh week is Kerala. Like that, they have given this. So it becomes easy for the IOA president to accept if they fall in the proper calendar. But unfortunately, some of the major states like Gujarat, Tamil Nadu, and West Bengal, they clash on the same dates every year. So if anybody follows the protocol of the IOA calendar, the president of IOA will give preference to attend that conference first instead of attending some other conference. The grievance cell committee should give time-bound results. So that's another thing. Justice delayed is justice denied. So we should use the digital platform more effectively so that we will discuss the matter quickly. Friends, I must congratulate my predecessor, Dr. R.C. Meena. Yes, he has gone through one of the worst patch. Nobody expected in the world that there will be a pandemic in this year. Probably he will go down the history of Indian Orthopaedic Association as a president in spite of all odds. In spite of all odds, even at some point of time, I was against having a conference. What Professor Yadav says is correct. Once we decided with Dr. Yadav that we are going to have conference, I got everything streamlined. I got it ratified by the EC as well as GBM. Now nobody can question whether this conference is official or unofficial, constitutional or unconstitutional. Thank you, Professor Yadav and Dr. Kanabar. You are the main supporters for me for this, and I thank you for your guidance. Because of these two gentlemen sitting here, I could take this challenge and say to so many people that yes, we are going to have this, whatever you say, you call it as unconstitutional, yes, fine, but we are going to have a mini IOACON. But you have seen, it's not just mini IOACON, it's a regular IOACON. Just the number of people sitting in the hall is slightly less, but what is there? We are having more than 3,000 people attending online, and they're all listening to me now. I don't think if it was only a physical conference, so many people would have been listening to me. Whatever I'm talking is being recorded and it is available anytime for anybody to see now. I request all of you to give a standing ovation to my friend, my elder brother, Dr. Meena. Thank you very much. Friends,
Thank you very much, sir.
I cannot say enough thanks to all my senior past presidents who helped me in the time of trouble, especially Dr. Shantaram Shetty, Dr. Lad, Dr. Rajshekaran, Dr. Taneja sir, and Dr. S.C. Goel sir. Of course, I have already told Dr. Yadav and Dr. Kanabar sir. With these few words, I like all of you to follow this theme and work, because I know there are many professors in the hall, there are many senior doctors in the hall. Please implement Atmanirbhar Orthopaedics, Indian at heart, global in competence. Thank you very much.
Wonderful speech, marvelous vision, kind words to everybody. This is quintessential Dr. Shiv Shankar for you. Always nice, always humble, always looking forward, and hardly have ever here said a single word which would be unlikable to any soul. So there's just a bit digression. I would inform the house, all the beautiful ladies and dashing gentlemen, that incumbent first lady of Indian orthopedics, Mrs. Preetam Meena, had just arrived. So I want, this was the lady behind all his crusades, all his battles, as Dr. Daima put that Rana's battle and Sanga's battle and all other Haldi Ghatis. Even History Channel has emphatically declared that Rajput warriors were better than Yakuza, Mafia, Irish Republican Army, and everywhere. So, anecdote of Ranas and Sangas is not local, it is global. As Dr. Shiv Shankar told us that Indian at heart and global in competence. So this Rajasthani warrior was emphatically supported by this lady, lean and thin in stature, with head and shoulder high to her peer and contemporary. Thank you, Babiji. And she's so humble that her husband is arranging food for 1,500 or 500, but she will not throw her weight around. She will request me to arrange one coupon if I can. Otherwise, just get some food for his son who has not arrived. I haven't seen a more benign lady in my life, besides my parents, that I would say. And then for all other lady in the house, although we have given a standing ovation, I just want to salute them. So beautiful ladies, my heart always skip a beat. They are all graciousness personified, a spring of youth, a fragrance of youth. Our coming first lady of IOA, Dr. Lalita Shivashankar, graciousness personified and fragrance of youth as well. Graciousness, meet fragrance and beauty. That is Mrs. Lalita Shivashankar.
Great lady of this house. सारका कहाँ पे? अरे आराधना जी प्लीज आप उधर कहाँ बैठा दिए हमारी सारका जी को इधर भेजो ना आप.
All four could have been sit together, but probably
सारका आओ ना.
the beauty has to be distributed. Probably this is what their plan. So they just occupied four corners.
सारका
could be their idea. We never know what goes in the mind. of this beautiful lady. All the time we cannot figure it out. But then after this photograph, I'll move to the next. So, gentlemen, give them round of applause. So then, hence we move to our next session, that is accepting and acknowledging our academicians, people who contributed. There has been a token of appreciation to Dr. S.S. Mohanty. He has not arrived. Then I would request Dr. Ajit Shinde to please come on stage. The committee want to give them a token of appreciation. Please. He's coming. And we will have Dr. N.J. Karne is no longer here. Probably he's left. So we will have to collect his certificate as well. Kiranda, is he here? Kiranda? I would request our outgoing Secretary General, Dr. Atul Srivastava sir, to hand over the charge to our newly elected Secretary, Dr. Naveen C. Thakkar.
Best services to the IOA. And Mr. President will make it success, Atmanirbhar Orthopaedics in a team, and will need suggestion from all the members of the IOA. Thank you.
Thanks for your words and inclusivity, sir. A wonderful team in the present past term, and a wonderful team will occupy the house. And then I will go ahead with the token of appreciation distribution. May I have Dr. Shakir Jati? He left. So next is Dr. Rajiv Raman has left. Dr. Abhimanyu. Dr. Abhimanyu, he was the backbone among the organizers. We also had a token of appreciation for Dr. Amulya Kumar Singh, Dr. Bhuvan Kumar Singh, Dr. Sudhir Kumar. Is the next horse in the pipeline or in the stable of Dr. R.C. Meena. He has got an uncanny ability to find people who will do better than their original capacity. Then I would invite Dr. Divyanshu Goyal to please do come on stage. Divyanshu Goyal. And collect his token of appreciation. He did a lot of back-end work, lot of backroom loose ends he cleared, and few people have left. Then I would invite Mr. Vijay Purohit to come on stage. Mr. Vijay Purohit. He has gone. From ICS Global, the organizers, the event team, ICS Global. Do we have Piyush Jha? ICS Global, anybody? Yes, Piyush Jha, please do come on stage. In this difficult times, you did a marvelous job, wonderful job. And Vijay has also arrived. Then, Mr. Vijay Purohit, if you are free from your work, which never ends, and both, yeah. Vijay has been diagnosed with how many elements? Corona has taken its toll. He has put his health, his peace online. Nagpal and Sons, Team Nagpal, please come on stage to collect your token of appreciation. Then Grover and Sons, Team Grover, I mean to say. Susilo Pathak, anybody, please do come. And when we go ahead, we cannot forget, we shouldn't forget the immense contribution from our other colleague. There are so many sitting in our house. I tell them in these moments we tend to forget, but I shouldn't forget Dr. Amit, Dr. Jakir, Dr. Ravin Lamoria, Dr. Pankaj Jain, and all my Dr. Rajkumar Harswal, these are the people who are doing the back end work and doing these day-to-day work, so we can execute these things. In these high moments, shouldn't forget them, our residents, all the people, they were there working day in, day out. Then I will invite industry colleague, Troika Pharmaceutical, for collecting their token of appreciation. Troika team, Team IPCA, Tynor, Allenger people, they were there. Allenger, Team Allenger, could you come please stand on stage? Yeah. From Team IPCA, Jule Singh Nirmalia and his team has come. Team Troika, please, आप आ जाइए on his work. Team Troika. Tynor Surgical. We cannot forget our sponsors who, without any social gathering, anything, they still agreed to. Next is Tynor Surgical, Pankaj and his team, and he's sang a wonderful song as last night. Good work, Pankaj. And then other people who supported, I would just take their name: MacLeod, Alchem, Striker, Aristo, Jaidas, I'm Oxporte, Matrix, Omnicoris, Aristo. These were all our supporters, and we shouldn't forget all our colleagues, our residents. They out, they work, Siddharth and other people, Karthik at AVs, everybody. Organization team has decided in lieu with IOA to give a citation to Dr. Amar Singh Ranawat that will send to USA for joining and supporting us.
So friend, in the end, and in the last but not least, as an organizing chairman and president of IO 2020, and now within a minutes, just immediate past president, I say that this conference has been attended by physically registered 670 pupils, on the digital platform by the 16,000 pupils, and displayed across the country and world as well. And many congratulations and well wishes and appreciations messages and mails are coming regularly on my account from the country and abroad. And the last, I would like to say, friends, again few words that बड़े-बड़े शहरों में और बड़े-बड़े फंक्शनों में छोटी-छोटी बातें और छोटी-छोटी गलतियां होती रहती हैं। उम्मीद करता हूं आप लोग उनको नजरअंदाज करते हुए, अगर कहीं रह गई हो तो हमें माफ करेंगे। मेरी तमाम टीम, ऑर्गेनाइजिंग टीम, माय डिपार्टमेंट, डॉक्टर दायमा, डॉक्टर बंसीवाल, डॉक्टर पंकज, डॉक्टर अनुराग, डॉक्टर रविंद्र, आरपी and Umesh, thanks to all and my all residents. And now I declare the end of this IOG annual scientific meeting, 65th annual conference of Indian Orthopaedic Association. And I invite you, all of you, for the coming 66th annual scientific meeting of Indian Orthopaedic Association, IOACON, Mumbai, will be held in the last month of 2021. Thank you very much, friend. I would like to give the award of excellence to the Arun, who did a lot of work day and night and a very busy schedule. Thank you. आप award और letter घर पहुंचा। अभी तो शायद इधर होगा। Thank you very much. Thank you very much.
Sir.
Yes, sir.
I request Dr. Ajit Shinde to come and invite.
Yes, sir. Ajit,
as
sir. Sorry.
organizing
Yes, sir. Ajit,
chairman
sir.
of
Please.
IOACON 2021.
Or if
Mumbai.
anybody want to say something, so please, in the last moment. Sir, Ajit, sir.
Dignitaries on dais, of the dais, and my dear friends. First of all, I congratulate newly elected President, my friend Shiv Shankar and Dr. Thakkar. At the same time, I congratulate outgoing President, Dr. Meena and Dr. Srivastav for their excellent work and this wonderful arrangement of the conference. Now it has become a challenge to me. If a person can arrange a conference in 2-3 months, I cannot say like that, ki I have given the task of IOA 2021 in the month of April and how I should arrange in the month of December. I'm sure with me, I'm fortunate, Central Committee President also is from Maharashtra. And I assure all of you, the Mumbai IOCON is going to happen. Either 100% physical. You don't worry. And now these people have shown partly physical and partly online. But we are going to do online conference at Geo Convention Center, and it will be the wonderful event. Academic as well as entertainment, everything. And I request all of you to come to this conference with all your families and friends. Just now Yadav sir has given me 66. It is a conference of 6-6. So at least I have to hit to 6. Otherwise you people will not appreciate my work. With these words, I thank you all of you. There are 2 persons, one Pradeep Kumar and second Treasurer Sandeep Kumar. I will need their help off and on as the organizing chairman of this conference. So be kind to me.
Always there for you, sir.
And also I congratulate this young man who has made this show wonderful. Thank you. Thank you very much.
Everything, a good thing has to end. So that this is what Dr. Meena has already announced. And now this is the news from the center that our awesome valedictory function and awesome conference is over. And we will all rise up for national anthem after this photograph session. Team Grover. Pathak. Thank you, everybody. And I must not forget to thank my family as well. 4 or 5 women in my life. My grandmother, Sushila Devi, my mother, Bhagwan Devi, my better half, my daughter, my brother's daughter, my niece, everybody. And thanks all the people, including Professor S.S. Yadav. Without him, and but that is the reality. That is the reality. Thanks, everybody. If I forget, Dr. Anurag, Dhakar, Dr. Pankaj, if I forget, then just you forgive the way Imran Khan was forgiven when he failed to forget his team's name after winning 92 World Cup. Now we're gonna start free paper. Dr. S.K. Goel, the information in charge of our department, everybody. If I forget, if I miss a word, बड़े-बड़े शहरों में हो जाती हैं बातें, but I apologize if I forget. One shouldn't get, good work shouldn't get into the head of anybody. So hall C and D, free paper pupil, you were on our back end call friends today, हमारा नंबर कब आएगा? आपका नंबर आ गया है, आप अपने halls में जाइए and read your papers. Then only you will get a certificate. If you don't read paper, you won't be given a certificate. Hall A, I'm just starting free papers. Let me talk like a professor. Dr. S.K. Rawat, you are probably next chairperson. You are here. Dr. S.K. Goel is here. He's also a chairperson. So, so gentlemen, this would be the last session. That was penultimate of free papers. Our honorary treasurer is free to move around. And for chairing the session, may I invite Dr. S.K. Rawat, Dr. Shiv Kumar Goyal. Amit is how much busy you are, Amit Agarwal? To chair the session of our climax session. All three young Turks would be actually have an eye for the detail, and Praveen Siddharth, do join the panel. We have 4 panelists now. So residents and students who are going to present cannot be let off the hook, because we might miss things, but these young Turks not gonna let off the hook. So first speaker. Atul Anand, our first speaker. Is he ready? Atul Anand. Prabhak Vish Atul Anand. कहाँ थे बेटे? हम तुम्हें ढूंढ रहे थे. Team Grover and Sons, ready? Sushil and Pathak and you people are fabulous यार. मजा आ गया काम करके. So the first talk would be on role of cost index in predicting risk of redisplacement in pediatric forearm fractures. Now, mic and stage is hand over to our 4 dynamic panelists and chairpersons. Stage is all yours, Dr. Atul Anand, please.
Dr. Atul.
Now, I would like to invite Dr. Atul Anand for the role of cast index in predicting risk of the redisplacement in pediatric forearm fracture. Please start your talk.
Good morning, everyone. I am Dr. Atul Anand from GRMC Gwalior, here to present a paper on role of cast index in predicting redisplacement after closed reduction and cast immobilization in forearm fractures. Forearm fractures, as we all know, are very common, and the incidence of this fracture in girls, the peak age of incidence is around 9 to 12 years, and in boys it is around 12 to 15 years. The closed fractures of forearm in children is generally treated with closed reduction and immobilization in a well-fitting plaster cast, and whatever there is, even if there is a bit of displacement, it gets already corrected by itself in children due to remodeling. However, in children more than 9 years of age, the remodeling potential is low, and hence redisplacement of fracture remains a complication, and it is as high as 25%. The quality of casting is actually a modifiable risk factor for fracture redisplacement. So there are various casting indices which numerically measure the quality of cast. Among them, the first and simplest index is the cast index, which was described by Chess et al. In 1994. The cast index is measured at the level of fracture by calculating the internal lateral diameter of the radiograph and dividing it by internal AP diameter of the cast at the level of the fracture, and it is all excluding the padding. Now, recent studies have shown that cast index of over 0.8 carries a significant risk of redisplacement in distal forearm fractures. The simplicity of calculation of this index and the benefits of this index is actually not being harvested in our country, and however, whatever studies have been done, it shows that it should be used as a standard protocol after reduction for assessment of cast quality. The hypothesis of this paper is that cast index will come out to be a good index in my age group 5 to 16 years with forearm fractures as far as risk of redisplacement is concerned. The aims of the objective of this paper is to prove credibility of cast index and to provide an ideal range of cast index and to statistically prove if cast index can be used as a parameter to assess the quality of casting in pediatric forearm fractures. The inclusion criteria of the study are the patients who give consent for the study and the age group being restricted to 5 to 16 years, and both monoosseous and biosseous closed forearm fractures were included in the study with trauma history not more than 10 days. The exclusion criteria was intraarticular fractures, comminuted compound and segmental fractures, and open fractures. So what we did was, as soon as the patient arrived in the OPD clinic or in the trauma center, we actually radiographed them for pre-reduction X-ray, and after the pre-reduction X-ray was taken, the patients were taken in the operating room, and under short general anesthesia, reduction was achieved. And post-reduction radiograph was taken. The post-reduction radiographs were then calculated for cast index using image meter software from the images using standardized calculation methods. The standardization was done by old 5 rupee coin having standard diameter of 23 millimeter. Then after that, the patients were called for follow-up after a period of 1 week and then at 4 weeks. Assessment of redisplacement after cast application was then done. And in our study, we took the redisplacement criteria as increase in angulation of more than 10 degrees in anteroposterior and or lateral views, or loss of adequate contact between fracture fragments. And in a few cases where there were unacceptable redisplacements, we tried to reduce it again, or in some cases even intramedullary nailing was done. The functional outcomes were not studied in this paper. So this is one of the examples in which the degree of angulation of the patient pre-reduction was done in AP and lateral diameter, AP and lateral views. Then using a 5 rupee old coin as a standard diameter, the cast index was calculated at 0 weeks. That means at the time of application of the plaster cast, then at 1 week, and then at 4 weeks. This is the observation that we got. The internal lateral diameter and the internal AP diameter is mentioned, and the cast index is calculated. The angulations before reduction, after reduction at 1 week and at 4 weeks is mentioned. So in this there was no displacement because the displacement of whatever it was less than 10 degrees.
Conclude your talk. Time is over.
So the results that were obtained in this ongoing study is total 20 cases have yet been followed with mean age 7.85 years. Out of them 3 were females and 17 were males. 8 of them were proximal fractures and proximal half of forearm, and 12 were distal half of forearm. The mean cast index from this study came out to be 0.837, compatible with previous studies. The mean cast index in proximal half of fractures was a little higher than the distal half of fractures, and redisplacement occurred in approximately 6 of them, with mean cast index in this group being 0.94. That suggests a higher cast index, and no redisplacement occurred in 14 of them, with mean cast index being 0.793, in line with previous studies. So cast index we find is the most basic and easiest to calculate, and it is actually very practical to apply a cast and get a X-ray done, and then follow it up with quick calculations to actually find out the quality of cast. So there are other casting indices as well, like padding index, gap index, Canterbury index.
Conclude your talk.
So These are some previous studies showing the efficacy of cast index. The cast index in proximal half of forearm was a bit higher because the cross section in proximal forearm is approximately circular than in distal forearm, which is elliptical. So in our study, cast index has proven to be a remarkable predictor of redisplacement, and it should be used as an objective assessment for quality of cast in pediatric forearm fractures. Thank you.
Thank you, Dr. Anand. Very nice talk, Dr. Atul. It's a very important topic that has covered by you. Recent days, what we are coming across that many youngsters and the new generation surgeons are started applying tensional in forearm fractures. But what my take is that most of the seniors will agree, if you maintain the proper cast index and you applied proper plasters in a right position, there is no need of doing any kind of tensionals in the younger generations. Thank you. It's a very nice talk. Thank you. That's a very nice and properly put point by you. Because now the younger generation, as we see, they are more prone about the operative work. Then when the complication occurs, then it's very difficult to treat.
Right.
So just in a pediatric patient, just simple, maintain a cast is the one of the best treatment.
And what should be the take-home message that, sir rightly said, if you come across osteomyelitis forearm bones in a young children, that will be a nightmare for you to deal. So both on clinical grounds and for your practice also, it's not good for you. Thank you.
Thank you, sir.
Thank you.
So next speaker is Dr. Siddharth. He will be talking on a comparative study of anteromedial, anterolateral, and combined approaches for open reduction, internal fixation of talus fractures.
Good morning, respected delegates and friends. Today, my topic is on comparative study of anteromedial, anterolateral, and combined approach in open reduction and internal fixation of talar fractures. Coming to the introduction, fractures of the talus are uncommon and accounts for about 0.1% of all fractures. Fractures and dislocation of the talus are challenging injuries to the most orthopedic surgeons. Talus is the second most common tarsal bone to be injured after the calcaneus. Talus fractures most commonly occur when a person falls from a height or sustains some other type of forced dorsiflexion injury to the foot or ankle. The classification system for vertical neck fractures of the talus, the commonest type of talus fracture, we classify as commonly by Hawkins classification, and body fractures are basically classified according to Sneppen classification. And talus has a characteristic tenous blood supply with the tarsal canal artery, which is a branch of posterior tibial artery, supplies the most of the talar body, whereas branches of dorsalis pedis artery and sinus tarsi artery supplies talar head and neck. Coming to the aims and objective, our aim was to review periodically with the EOFAS scoring and radiologically with X-rays till union achieved. And the objectives were to compare the success rate of various approaches, anteromedial, anterolateral, and combined, and its clinical outcome. And we also did this study to find out the various proportion of postoperative complications. Coming to the material and methods, this study included 75 patients from April 2019 to November 2020. Type of study was a hospital-based, quantitative, prospective, randomized from Chitbox method. It is an interventional comparative study. Coming to the inclusion criteria, we included all talus fractures, head, neck, body, lateral process, and posterior process, and associated fractures like calcaneum and pallian fracture. And we also included compound fractures up to grade 2 of Gustello-Anderson classification, and we excluded children below 14 years. And coming to the approaches, anteromedial approach, we took an incision of around 10 centimeter log, which begins at the lower third of the leg, 1 centimeter lateral to the anterior crest of the tibia, which runs parallel to it, and then we curve medially to midway between the tip of the medial malleus and the navicular bone. And we also did medial malleus osteotomy to better visualize the talus, and we achieved reduction using K-wires. Coming to the second group, which is anterolateral approach, we used classical sagittal one. Here we palpate the base of the fifth metatarsal, and we make a 50 centimeter slightly curved incision on the anterolateral aspect of the ankle, which begins around 5 centimeter proximal to the ankle joint, ending some 2 centimeter medial to the fifth metatarsal base. Here are some of the pictures. We retract extensor musculature medial to expose the anterolateral aspect of talus and ankle joint, and fracture is fixed with 4 mm Arbut screw. Coming to the AOFS Eintfurt grading, here total is 100 points. Pain has got 40 points and 50 points for function and 10 points for alignment. Coming to the results, the age of the patients in our study ranged from 18 to 59 years, and the mean age was 35 years. And there were 26.7% of females and 73.3% of males in our study. There were most of the patients suffered fracture due to RTA of around 78.7%, and most of them had closed fractures of around 88%. And there were 21.3% of the patients who had body of talus fracture, 8% had head of talus fracture, and most of them had neck of the talus fractures. This is a graph which shows interval between the injury and surgery, also the duration of the surgery. Here we can see group C patients took more time of around 11 minutes, as we did both anteromedial and anterolateral approach, and group A, group B took a similar time. And interval between the injury to surgery was 7 days in group A, 8 days in group B, and 8 days in group C. And coming to the AOFS Eintfurt score, results in AOFS score were statistically significant during preoperative and postoperative follow-ups, except at the 12th month follow-up. We got most common complication as arthritis of around 28%. In that, subtalar arthritis was the most common, then tibia talar. We had no case of talonavicular arthritis in our study. And the second most common complication was avian for around 18.7%, non-avian was for 4%, malunion was for 4%. From the discussion part, in our study, age was ranging from 18 to 59 years, mean age was 34.32 years. This correlates well with the Marsh et al. As 31.4 years. And as the RT was the leading cause, which correlated with the findings of Carlo Bees et al. And we also correlated with the Leo et al. 2017 as 65.6 minutes in duration of surgery, primarily for anteromedial approach. Thus, we conclude that open reduction and interfixation of talus fractures with combined approach of anteromedial and anterolateral incisions provide better visualization of talus fracture and early bone union, but it takes longer duration of surgery, leading to increased postoperative complications. Anterolateral approach was better in showing few postoperative complications and decreased duration of surgery, but bone union was delayed. Patients operated with the anteromedial approach had overall better clinical and functional outcome in terms of AOFS grading, but limitations in our study include short duration of follow-up. A long term of study is required to substantiate our results. Coming to the clinical illustration, a case, we have a picture of preoperative CT scan and X-rays. This is an Hopkins type 3. Here we can see subtalar dislocation and also tibial dislocation is also associated with middle malleus fracture. Coming to the immediate postoperative, here the patient was fixed from KOS due to there is no availability of implants. This is second one is a first month follow-up, and this is an image of 4th month follow-up. We can see clearly changes of subtalar arthritis, and at 8th month follow-up, we can see it's tibial and subtalar arthritis changes. And coming to the 12th month, here is a deaded complication, like there is a collapse of dome of the talus, which avian changes with marked tibial and subtalar arthritis, even though patient had a healthy wound at that time. These are some of the movements. Plantar flexion of 7 degrees at 12th month follow-up, ankle dorsiflexion of 5 degrees at 12th month follow-up. Here's a eversion and eversion movements. These are my references. Thank you.
Thank you, Dr. Siddharth. The most important thing about this talar fracture, it is the fracture with always unite with complication. Right. Patient never happy with the talar fracture, because most of the part of the talus is covered by the articular surface, superiorly ankle joint, anteriorly talonavicular joint, and down the subtalar joint. In my practice last 15 years, I have seen no patient who says I am perfectly alright. So take home message to younger patient, a younger orthopedic surgeon, if you get
the talar fracture in your initial days of patient, better not to treat. And refer to some specialized center. Otherwise, that patient is giving to bother to 100%. And that patient never satisfied of the talus. He always have the pain and arthritis.
Yes, sir. Right, is it, sir? Dr. Siddharth, I have two questions for you. First of all, I congratulate for the very good presentation. How will you approach, suppose you get a scenario where the fracture is predominantly on the posterior aspect or it is dislocated posteriorly? The first question is how are you going to approach them and what time you will decide that fixation is not a good choice. I'll go for first hand orthodesis. Right?
Sir, first you have to look for the skin conditions like if we see any blisters and we should wait for the definitive surgery, sir. And first reduction of the dislocated talus is a emergency.
Two questions, I'll repeat it again. First is how you will approach. By these two approach, you cannot access to the posterior corner of the talus, right? So if you have a fracture which is prominently toward the posterior side of talus, what approach you will take? How you will approach that corner, the posterior part of the talus, the tubercle and all?
Sir, anteromedial approach is good.
No, you have to do little homework. That's over for you, right? And second question is that at what time, like you have a patient with a highly comminuted fracture, talus dislocation, big combinations are there. You know that addressing such fracture is a very complex scenario and result in these cases is quite unpredictable. Like good favorable result hardly you will get, like sir was mentioning. So at what time, at what presentation you will think fixing it, arthrodesis is the right answer for the patient. So case selection, how you will do it?
Sir, for a severe comminuted fractures and compound grade 3B fractures, any extrusion of talus cases, we go for orthodesis.
Yes, that's the right answer. That's right.
Thank you. Orthodosis still has a role in the fracture talus.
Exactly. Like I come across a patient, I think last week, he had compound grade 3A fracture, comminuted, highly comminuted fracture with a delayed presentation. In such scenarios, fixation is not a good option at all. That was a very important message. Okay, thank you. Thank you very much.
One more point. Once you give the choice for the orthodesis, then which implant is preferable? That is again a matter of debate.
Yes, that's
Which
we'll
implant
cover
you will use?
For
Whether you use the nail or Charney clamp or plate or screw, there's a lot of inventory of implants.
Yeah.
So which are you going to use? That is very important.
Sir, nail.
Which?
Or
You
we can do orthodesis with simple screws, sir. Screws.
It's a huge topic.
It's a very
But-
small bone, but it is a discussion is endless.
And one more thing I've seen in your presentation, there was a highly comminuted fracture of talus and you fix it with some screws and all. So most important factor that is determining then a comminuted fracture, if you're going for fixation, that how you will maintain the length of the talus. And for that cases, if high combinations are there, you can use mini plates also. This is well documented nowadays also. Go through it. That will help you. Thank you.
Thank you.
Dr. Vishwas Kumar, Braun method of reduction of pediatric supracondylar humerus fracture.
Hello. Warm good afternoon to each and everyone here. I am Dr. Vishwas from Mysore Medical College, cultural capital of Karnataka. So here I am here. We thank Dr. Shobha and Dr. Sunil for guiding me to this presentation. So it's Braun method of reduction of pediatric type 2 supracondylar humerus fracture in OPD setting. So supracondylar humerus fractures are the most common fractures in the children and requiring surgery, which if not properly treated, can result in serious complications. The peak age, can you hear me?
Mic is not working properly.
Hello. Okay. Hello. Yeah. Thank you. The peak age range at which the most supracondylar fractures happen is around 5 to 6 years. Extension fractures, which approximately account for 97 to 99%, are usually due to fall on outstretched hand. So the management varies depending on the magnitude of displacement of the posterior fragment. So this is a classification as put forward by Gartland, modified by Wilkins, as you all know. Type 1 is a non-displaced fracture. Type 2 is a minimally displaced fracture. 2A comes with no rotational component. 2B with the rotational component, and type 3 is a completely displaced fracture. So type 1 fracture, it's a conservative approach. Type 3 is an operative approach. Type 2 fracture is the gray area. Some will go for a conservative, some will say go for a operative, depending on how are you really able to reduce the fracture fragment. So we come up with a technique of reducing this type 2 reduction, type 2 fractures, where we had very good outcomes. So usually, generally, this is the method we follow to reduce the type 2 suprahumerus fractures, as told by Sir Chanley. In this method, although the medial lateral corrections are well achieved, we observed that in quite few cases, the posterior tilt of the distal fragment was not properly reduced. And as a result, the child has to undergo an operative intervention and expose himself to the complications associated with it. So inspired by the Stimson's gravity method and L. Prakash method, we come up with the prone method of reduction. We like to call it the Mysore method of reduction. So the aim was to assess the efficacy of the prone method of reduction in type 2 suprahumerus fractures. So also to compare the carrying angle at the follow-up. See, this is a prospective study with 1 year from Jan 2019 to 2020. 25 people were there. The inclusion criteria was type 2 suprahumerus fracture humerus. Age group was 4 to 12 years. We excluded all the type 1 and 3 open fractures, comminuted fractures, and pathological fractures. So we are coming to the procedure that we are following. First, the patient is made to lie in the bed so that he can relax, and also we'll allow the gravity to play its part. Usually when the child falls down, the distal fragment goes posteriorly. So we are reversing the pathology and allowing the muscles to relax and the distal fragment to come down. Next, counter traction is applied at the axilla by an assistant and traction by the surgeon at the forearm, and also thumb at the olecranon. As mentioned by Sir Chanley, it's imperative not to flex the elbow until medial lateral correction is achieved. Now I keep the thumb on the olecranon, fingers wrapping around the proximal fragment while giving traction in the other hand. If there is one more assistant, he can give the counter traction at the same time, check the integrity of the radial pulse. My both thumbs will be on the olecranon and proximal and fingers on the proximal part. Now I flex the elbow as much as possible till the radial pulse is intact. I apply cotton with the thumb on the olecranon. Well, at the same time, we are checking the integrity of the radial pulse, and then the salve is applied. For the posterolateral displacement, we keep the forearm in supination, and posterior medial displacement, we keep the hand in pronation. So above elbow POP slab is applied. Window is made in the slab to check the integrity of the radial pulse, and once it is confirmed at as much as flexion possible, we have done it. Arm sling applied and child is sent to X-ray to assess the adequacy of the reduction. So follow-up. So the child was followed every week. So at the end of 1 week, we took the X-ray, and if the when most of the reduction were still maintained, and we converted the above elbow cast, we tried to flex even more up to 110 degrees so that triceps will lock the fracture. And cast removed when there was sign of clinical and radiological signs of pinion at 3 to 4 weeks, and joint mobilization started, and also followed up for 6 weeks and 12 weeks. Based on the above results of the, and we used for Flynn's criteria to check the assess the results. So it is the range of motion of the child at the final follow-up. We can see it was all intact. In the carrying angle, there was intact. So the X-rays, first the child came with the type 2 suprahumerus fracture. We reduced and tried to flex as much as possible up to 110 degrees so that triceps will lock, and follow up. It's very well reduced by this method. Even in supine method, what we found was the distal fragment used to have a posterior tilt, and used to prone method, we are pushing it. We are keeping our thumb there. Put your thumb where the displacement is, and as a result, we are able to very well reduce it and avoid any further surgical embarrassment. So these are all the X-rays what you have done, and where all the Bowman's angle, everything is maintained, and we are very happy with this. So excellent results is seen in 20 patients out of 25, good in 2, fair in 2, and poor in 1. And what are the complications? One patient required a pinning because of secondary displacement. At the 1 week, the reduction was, as we saw, it's not maintained. So the possible results, the reasons could be, it was maybe an incorrect technique, not adequate elbow flexion, unstable fracture pattern. And cubitus varus was seen in first one patient because maybe we overlooked the medial wall combination and irregular compliance and follow up with the patient. What is the limitation of this study? It's not a comparative study. It's a small sample size. And we can also use this in type 3 supranuclear humerus fractures, where where the reduction is done, and our job is very well easier in OTs. In OTs, the fracture is already reduced and we can directly go for pinning. And also we saw some cases where child went DAMA after the slab and he comes after 3 weeks because ours is a real remote area. And we've seen a very good outcome, even type 3. And it's a very good method of reduction is what we saw. So prone method of reduction is a very efficient method to reduce supranuclear humerus fractures. The posterior tilt of distal fragment is very well corrected and reduced anatomically by method. Further research with the bigger sample size and comparative group would give us an even better insight. Thank you.
One question, Dr. Vishwas.
Yes, sir.
Do it with anesthesia or without anesthesia?
No anesthesia, sir. Child was very comfortable. We didn't need much
In
traction.
children,
Also.
supraorbital fractures are very painful, and
sir,
the child doesn't allow you to even the touch.
Yes, that's
It
why
is very difficult to reduce the supracondylar fracture without anesthesia.
That's right, sir. By this method, the child has very little very little traction, and so first 5 minutes we allowed him to relax.
Patient
And
doesn't allow to even the touch.
yes, sir. That's what we are saying. By this method, he was very comfortable.
Even prone position is also painful. As you compared it to supine position, it may be some helpful, the biological help,
yes, sir.
but it is still painful.
Yes, sir. It's in the OPD setting, in a setting where there are not many facilities available. So we find it's a good method.
It's a very nice technique, worth trying. But sir rightly said, giving GA or some sort of hematoma block will help,
Yes, sir. Yes, sir.
to reduce the pain.
Yes,
Thank
sir.
you. Thank you very
I
much.
agree. Thank you,
It's
sir.
very nice talk.
Thank you, sir.
Next is Dr. Anand Kumar Gupta. Variation in the course of the lateral femoral cutaneous nerve during anterior exposure of pediatric hip, an observational study.
Good afternoon, everyone. Myself, Dr. Anand Kumar Gupta, third year PG resident from LHMC New Delhi. I am going to present the presentation of my thesis, which was on variations in the course of lateral femoral cutaneous nerve during anterior exposure of the pediatric hips and observational study. As we know, the lateral femoral cutaneous nerve is a sensory nerve which supplies and innervates the skin over the anterolateral part of thigh and skin around the trochanteric region. And it is usually dissected into anterior approach to the hip joint. And as we know, the anterior approach to the hip is commonly used in orthopedic procedures and mainly used in pediatric orthopedic procedures. And the most common complication in this anterior approach to the hip is injury to the LFCN. So chances of the injury to the nerve increases if the course of nerve is altered. And if the nerve gets injured, it leads to tingling and burning sensation over the anterolateral part of thigh, which is known as meralgia paresthetica. So the aim of our study was, there is a lack of literature regarding the surgical anatomy of LFCN in pediatric age group, and the studies which are available are mainly based on cadaveric studies and those done on adult population. So due to lacunae in the existing literature, this study was aimed to find out the common pattern and variations in the course of lateral femoral cutaneous nerve during anterior exposure of the pediatric hips. So we made a research question that is there any variation in the course of lateral femoral cutaneous nerve in relation to the anterior superior iliac spine in the pediatric age group. And in this study, we made ASIS as the surgical reference point to study the nerve. So in our study, 31 pediatric hip surgeries were done on 28 patients, as 3 patients were operated on bilateral hip. And this study was conducted from August 2018 to March 2020 at Lady Hardinge Medical College, New Delhi. And inclusion criteria of the study was age of the patient 1 to 15 years and planned for surgery for various indications like septic arthritis, DDH, TB hip and others using anterior approach to the hip joint. And we excluded the previously operated cases. And in all the cases, we operated with Somerville anterior approach to the hip joint. So in our study, although in all the procedures, we used a bikini shape incision. A bikini shape incision is made from 1 centimeter below the iliac crest, from the midpoint of the iliac crest to mid inguinal point, keeping ASIS at the midpoint of the incision. And lateral femoral clitoris nerve was identified and dissected, and it was studied in relation to the ASIS, sartorius, TFL, and inguinal ligament. So after dissecting the nerve, we studied two parameters. One was observational parameters and second was measurement parameters. In observational parameters, we studied three things. What is the relation of the nerve with relation to ASIs, whether it is medial or lateral to ASIs. As you can see in the diagram, we were seeing the nerve whether it is medial or lateral. And in second, we studied the relationship of the nerve with inguinal ligament. That is whether it is coming below the ligament or coming up from the ligament or coming through the ligament. And we also checked for is there any more than one number of branches or branching pattern of the nerve. What do we mean by branching pattern of the nerve? The branching pattern of the nerve was first given forward by Rudin et al. In 2016 in their paper. There are three types of branching pattern of the LFCN. One is sartorius type, second is posterior type, and third is fan type. In sartorius type, there is a dominant anterior branch which goes through to the sartorius muscle. In posterior type, there is a dominant posterior branch which goes towards the TFL muscle. And in fan type, there are multiple small branches fanning out from sartorius to TFL. So in our study, we have observed all the three branching pattern. In the left diagram, you can see this is a sartorius type pattern where there is a dominant anterior branch going towards the sartorius muscle. And in the posterior type, you can see in the diagram, there is a dominant posterior branch going towards the TFL muscle, and there is a small branch which is going towards the sartorius muscle. And this is a diagram showing of fan type of branching where more than 2 to 3 branches fanning out from sartorius to TFL muscle. So these were our three observational parameters. Now coming to the measurement parameters. We measured 4 things in relation to the nerve. First was, what is the distance of the nerve from ASIS? It was horizontal distance measured from ASIS to the nerve at the level of inguinal ligament. Second distance was, what is the vertical distance of nerve from ASIS to the crossing of the sartorius, and what is the vertical distance from ASIS to nerve at the level of first branching. And fourth, we also measured what is the angle between nerve and inguinal ligament. So I will show you some diagrams. In this diagram, you can see, first of all, we dissected the nerve, we marked the ASIS, and we measured the distance from nerve to ASIS with the help of sterile measuring scale. How we have measured vertical distance? The nerve is dissected, ASI is marked, and the crossing of the sartorius muscle is pointed out, and this distance is measured vertically from ASI to that point. As you can see in the diagram, the nerve is present. There is a first point of branching, and this point is noted and measured with the scale from ASI to the branching point. After these 3 measurements, distance angles, we measured 4th point, that is an angle. Angle was measured by keeping a piece of paper along the ligament and along the nerve and measuring this angle with the help of digital phone or any other measurement. So at the end of our study, we have operated 31 cases in that period, but we could study the nerve in only 28 surgeries. In 3 surgeries, we could not able to study the nerve because in 2 surgeries, we could not able to dissect the nerve. We could not find the nerve in our surgical field. And in one study, the nerve was iatrogenically injured during the study. So in 31 out of 28 cases, we found the nerve and studied further. And in one case, it was iatrogenically injured in the case of septic hip dislocation. So in all the 28 surgeries, we observed that nerve was coming medial to ASIS and coming under the inguinal ligament. And among the branching pattern, the most common was sartorius type, followed by posterior type and fan type. The mean distance, horizontal distance of nerve from ASIS was 1.14 centimeter. Mean angle was 58 degree. Vertical distance at the level of sartorius was 2.39, and vertical distance at the level of first branching was 0.58. So, and we tried to correlate these measurements with the age and anthropoparametric measurement of the patient, that is height and length. So we found that there was no correlation between age and anthropometric measurements of the patient. That signifies that with the age increasing or decreasing, the nerve does not comes closer or far from the ASIS or other surgical landmarks. So the variations in the course of nerve was investigated by several authors in the past, like Azwan et al., Dirider et al., Hospital et al. And in all their studies, the majority of the nerve was found medial to ASIS and coming under the inguinal ligament. That was relevant in our study, that we found in 28 cases, the nerve was medial and coming under the inguinal ligament. The finding in the previous studies on the distance of LFCN from ASIS along the inguinal ligament were different from our study, confirming that those values cannot be applied in the pediatric population. This table shows the distance what we measured and what was measured previously in the several authors. This signifies that their distance were measured in the adult population and does not correlate with our finding that these measurements cannot be applied to the pediatric age group population as they were on adult population. Coming to the conclusion, the nerve can be easily identified in the anterior approach to the hip if we search in the area of 3 into 3 centimeter below the ASIS, and variations in the course of anatomical course of LFCN are observed in our study. We have observed 4 variations in our 31 cases. In 2 cases, we could not find the nerve. In 1 case, it was overlying the ASIS, it was injured. And in 1 case, there were multiple branches at the level of ligament. And there was no correlation with the age and height of the patients. And the nerve can be protected from the injury if we search in the area, if we are aware with the different type of branching pattern and the course of the nerve. And then limitation of the study was there were a small number of patients and the lack of published literature to compare our study. Thank you. And the aim of the study was to preserve the nerve at the end of surgery.
Thank you, Dr. Anand. Yes, any question from the audience? The next speaker is Dr. Chiranjeevi KV. The comparative study of the percutaneous lateral pinning and the cross pinning in the treatment of type 3 supracondylar fracture of humerus in children.
Good morning, everyone. My topic is on a comparative study of percutaneous lateral pinning versus crisscross pinning in type 3 supracondylar fracture of humerus in children. Most supracondylar fracture is the most common fracture around the elbow in children, occurs in 60% of elbow fractures. 95% of these are extension type, which produces posterior displacement of the distal fragment. Ligamentous laxity and hyperextension of the elbow are important mechanical factors, may be associated with the distal radius of forearm fracture. Gartland's classification, there are 4 types. Type 1 is non-displaced. Type 2 is displaced with variable angulation, but posterior cortex of the humerus is intact. Posterior tilt is type A and posterior translation is type B. Type 3 is completely displaced with no cortical contact. Type A is posteromedial and type B is posterolateral. Type 4 is complete periosteal disruption. Clinical X-ray of supracondylar fracture. Mechanism of injury, it's a fall on outstretched hand with hyperextension of the elbow with abduction or adduction with hand dorsiflexed. The clinical signs include where we look for local signs of ecchymosis, 3 bony point relationship, restricted movements, particularly extension, the S-shaped configuration of elbow, anterior pucker sign, thorough motor, sensory, and vascular examination should be done. This is a picture of anterior pucker sign. This is a picture of S-shaped deformity. The X-ray findings, signs in AP view are Bowman's angle, humeral ulnar angle, metaphyseal diaphyseal angle. If the Bowman's angle is increased by 5 to 15 degrees, it should not be treated conservatively and it should be treated surgically. The signs in lateral view include teardrop, shaft condylar angle, anterior humeral line, coronoid line, and fat pad sign. Treatment for type 1, immobilization of elbow in a slab and check X-ray in 5 to 7 days, slab for 3 weeks. Type 2, closed reduction with POP of fixation. Type 3 is closed reduction with K-wire fixation under CM guidance. Most common methods of treatment in closed reduction and K-wire under CM guidance. Types of wiring are crisscross wiring, and type 2 is lateral wiring, which can be parallel or divergent. The study to my abstract study to compare the result of lateral pinning and crisscross pinning in management of type 3 supracondylar fracture of humerus in 45 children at the Department of Orthopaedics in Vinayaka, June 2019 to 20. All patients were operated immediately by closed method. In 17 children, two parallel lateral pins were placed 1 centimeter apart, and in 28 children, one lateral pin and one medial pin passed after milking of ulnar nerve. Materials, it's a retrospective and prospective study of 45 cases of type 3 supracondylar fracture. Clinical data and radiographs were taken. Data related to age, gender, side fracture, and surgical details and pin configuration. Analysis of results with regards to ulnar nerve injury, carrying angle and range of motion was made in 17 children with lateral pinning and 28 children with cross pinning. The outcome was graded using Mitchell and Adams criteria. Methods: patients were assessed, no neurovascular injury, and X-ray was taken. All cases were treated, had emergency fixation and treated by close reduction pinning. Under general anesthesia, patient in supine position, under C-arm guidance, stepwise closed manipulation was done. Reduction is assessed clinically and radiologically. Reduction technique, it was under general anesthesia with longitudinal traction, lateral rotation, and lateral tilt. Slow tilt and slide of the distal fragment distally and anteriorly, and the reduction was assessed in Jones view in the C-arm, and Bowman's angle was calculated. Reduction technique. Insertion of the pin through the medial epicondyle after milking of the ulnar nerve. This is a clinical picture of our lateral pinning and picture of cross pinning. So maintenance of reduction done by passing 2 KYS from lateral condyle in parallel fashion or by passing crisscross KYS after milking of ulnar nerve. After the pins were placed, reduction was checked under C-arm. Follow-up X-rays were taken at the end of 1 week to check any loss of reduction. Later, KYS were removed at an interval of 3 to 4 weeks in an OP basis. Active mobilization exercises were started at the end of 4 weeks after the removal. Follow-up was done at 6 weeks, 3 months, and 6 months. The pins were removed after radiological union at 4 to 5 weeks. Immediate mobilization was started. Patient was assessed according to range of motion, deformity, and neurological status. By this study, there was no difference in the loss of reduction, union rate, or range of movement and deformity in both the groups. We found that both crisscross pinning and lateral pinning had a very good outcome. Conclusion: since the lateral pinning technique is simple and reproducible, lateral pinning can be practiced safely, therefore avoiding the possible iatrogenic nerve injury by crisscross pinning. Thank you.
If you are doing the cross pinning, what precautions you take to prevent the ulnar nerve injury?
We should go more hyperflexion.
Use mic.
Hyperflexion should not be done.
No, why hyperflexion? How can prevent the ulnar nerve injury once you are putting your medial pin? How many cases of cross pinning we have done?
20.
20. Is there any medial nerve injury in that?
No, sir.
Honestly? Thank you.
Thank you.
Next speaker is again Dr. Vishwas. Functional outcome of closed versus open K wiring in displaced pediatric supracondylar fracture.
Vishwas, second one.
This is your second talk, no?
Yes.
Be particular about the time.
Yes, sir. I'll be very fast with this. I already talked about type 2 method where we did conservative. Now I'm talking about type 3 method. It's a functional outcome of closed versus open in type 3 method. I'll skip to the introduction. Already Dr. Chiranjeev has told it well, and I told in the old method. So although closed pinning is a preferred method to treat type 3 displaced supracondylar humerus fractures, few surgeons still watch for open reduction. So effective treatment is necessary in order to avoid any serious complications like cubitus varus, malunion, limitation of movements due to pain or any nerve injuries. So aim was to compare open and closed method and compare the carrying angle at the final follow-up. It is a retrospective study. So we looked the world records from January 2019 to January 2020, 20 in both groups. There are two different units in our hospital. One unit followed the protocol of direct open approach to any type 3 humerus, and other unit followed closed method to all the closed method for all the type 3 humerus. So two different units following different protocols, one open, one closed. All the type 3 suprarenal humerus fractures, 4 to 12 years, excluded all the open fractures, 1 and 2 comminuted and pathological fractures. General preoperative working was done, analgesics given, patient selected on the basis of inclusion exclusion study. So close reduction, internal fixation, under CM wire, we used 1.6 to 2 mm K-wires. Two smooth K-wires were inserted through medial and lateral side. The K-wires were bent and cut, and were when the sign of radiological union at 3 weeks, it was removed. Open fixation by a posterior, we usually follow posterior approach there. Posterior approach, the triceps was split, and we put two K-wires to the medial and lateral side. The ends were cut to remove that. When the radiological union happened, it was removed and mobilization started. The patient were followed up for 2 weeks, 6 weeks, and 12 weeks, and were assessed as per the Flynn criteria. And statistical data was present as mean plus standard deviation using SPSS software and ANOVA. So results, as you can see, there are similar comparable results, and I'll talk upon that more. So this is the carrying angle when open and closed, and we have a scar in the open approach. X-rays of closed and open approach at 3 weeks and at 3 months. So what are the complications we saw? In closed approach, we saw ulnar nerve injury because we are not due to problematic technique, and cubitus varus sometimes we're not able to align the fragment well. In open approach, where we saw terminal flexion loss in patients and a recurvatum. So the varus angulation, even with excellent functional outcome, was considered the main cause of poor and post closed group. The closed group can go for varus angulation. In open group, there's significant range of motion loss. So was cured as fair results. And one patient had a 20% varus angulation. Pin tract infection were in 2 in each group. Perfect range of motion was observed in all the closed groups, but open group had a terminal flexion loss. Ulnar nerve weakness was seen in one closed group. While putting the pin, maybe it would have been injured. And there was no patient which needed any reoperation, and we found the cross pin technique was quite stable. Statistically, there was no significant difference between patients of group 1 and 2 by Flynn's criteria. So those who advocate for the open technique frequently say that closed fracture requires additional trials of to require anatomical rotation. There is this may result in elbow stiffness and finally with myositis ossificans. But the surgeons who advocate the closed method say that it has very few complications, and there is no loss of range of motions. So in the earlier studies, open reductions were tried after an trial of closed method, but in our one unit, they directly followed the open method. So maybe that's why we don't see much disparity between the open and closed method. So that's what I'm saying. The cross pinning method was used, which we found very stable. But in open group, we found there is a longer post-operative group. Post-operative has the child had to stay more in the hospital, and there was a scar and also higher financial cost. So in conclusion, I will say that between the two groups of patients treated by closed and open reduction techniques, there was no significant difference in the final outcome of the patient, but the open required more hospitalization time, scar. So what we'll suggest is, in circumstances that do not, we can directly go for closed reduction, but in circumstances which do not support any closed reduction, ORIF will produce nearly the same success with an almost negligible rate of complication. Thank you.
Any question?
Thank you.
The next speaker, Dr. Prashant Gupta, comparison of the outcome of supracondylar fracture of humerus in children treated with cross pinning and the lateral pinning.
Good morning, everyone. My talk for today is comparison of outcome of supracondylar fractures of humerus in children treated with cross pinning and lateral pinning. Supracondylar fractures of humerus are the most common elbow injuries in children and make up approximately 60% of all elbow injuries. The high incidence of residual deformity and the potential for neurovascular complications make supracondylar humeral fractures a serious injury. Great diligence is required to secure an excellent result and to avoid complications such as malunion, stiffness, permanent nerve injuries, and myositis ossificans. The aims of this study were to compare the functional outcomes of supracondylar fractures of humerus in children treated with cross pinning and lateral pinning. We used modified Gartland classification for all the patients, which has been discussed by previous speakers. The study was conducted in Department of Orthopaedics, GLN Medical College and Hospital Ajmer from December 2018 to June 2020. It was a prospective study with a follow-up period of 6 months. We included all children between 3 to 12 years of age and those that presented within 1 week of injury, age less than 3 years or more than 12 years, undisplaced fractures and pathological fractures were excluded. For the surgical technique, prior to reduction, a careful inspection of the soft tissues was performed to look for degree of swelling and tethering of dermis over the humeral shaft, which is known as pucker sign. In the OT, a period of gentle but sustained traction is maintained for 5 to 10 minutes. Then angulation and translation are corrected by direct manipulation with the elbow initially extended and the thumb positioned over the olecranon and pushed distally and anteriorly whilst the elbow is smoothly flexed. Then the reduction is verified and AP and lateral views in image intensifier. For lateral pinning, the first K-wire is inserted within the lateral column and should achieve a strong purchase in the medial cortex of the proximal fragment. The second K-wire is inserted from the lateral side into the medial column. The pin is spread at the fracture site should be more than 1/3 of the bone diameter. For cross pinning, the first lateral pin is inserted as described above. Then the elbow is semi-flexed and medial epicondyle is palpated and approximately 1 centimeter longitudinal incision made directly over the prominence of the medial epicondyle. The K-wire is inserted through the medial epicondyle and across the fracture in the medial column. Coming to the observation and results, 32 patients were included in this study, and most of the children were in the 5 to 7 years of age group. 19 patients had left side involvement. There was a male predominance of 66%. Most of the fractures were of Gartland type 3, that is 91%, and type 1 and most of the type 2 fractures that we were able to manage conservatively, so that they were excluded from the study. And fractures that are unstable in all planes, that is type 4 Gartland, those were also excluded from the study because they were managed by open techniques. And among the type 3 Gartland fractures, 76% had posteromedial displacement. So we used cross pinning in 17 patients and lateral pinning in the rest 15 patients. Average time for radiological union was 4.6 weeks in cross pinning group and 4.7 weeks in lateral pinning group. Mean loss of range of motion in cross pinning group was 10.35 degrees and in lateral pinning group was 10.53 degrees. Mean loss of carrying angle in cross pinning group was 3.4 degrees and in lateral pinning group was 4.1 degrees. And the average change in Bauman's angle in cross pinning group was 5.2 degrees and in lateral pinning group was 6.1 degrees. And according to Skaggs grading for Bauman's angle, 11 patients in cross pinning group and 6 patients in lateral pinning group had no displacement, that is less than 6 degrees change. 6 patients in cross pinning group and 9 patients in lateral pinning group had mild displacement, that is a change in 6 to 12 degrees, and no patient in either group had major displacement more than 12 degrees. 4 patients in cross pinning group and 3 patients in lateral pinning group had superficial infections at 4 weeks of follow-up. Infection resolved after removal of pins, and none of the patients had infection at subsequent follow-up. None of the patients developed deep infection at any time during follow-up. 1 patient in cross pinning group developed ulnar nerve palsy after surgery that resolved at 3 months of follow-up. No patient in lateral pinning group developed any kind of nerve palsy. So we use the Flynn's criteria for evaluation of outcome, which comprises of the functional criteria depends on range of motion and the cosmetic criteria that depends on loss of carrying angle. In cross pinning group, in the functional criteria, 16 patients, that is 94.1%, had satisfactory results, while in lateral pinning group, 86.7% had satisfactory results. 1 patient in each group had poor result, but the results were the difference was statistically insignificant. In the functional criteria, in the cross pinning group, in the cosmetic criteria, in the cross pinning group, 94% had satisfactory results. In cross pinning and in lateral pinning group, 93.3% had satisfactory results. And again, the difference was statistically insignificant. So these are the pre-op and post-op X-rays and the follow-up X-rays along with range of motion pictures in the cross pinning group. And these are the same pictures for the lateral pinning group. To conclude, in our study, we observed that closed reduction and percutaneous pinning is an excellent method for treatment of displaced supracondylar fractures in children. Cross pinning these fractures with careful technique which safeguards the ulnar nerve gives excellent results. Lateral pinning is an equally good treatment choice, especially for grossly swollen elbows in which the medial epicondyle is barely palpable with an increased risk of ulnar nerve injury during the placement of medial pin. Both the methods offer consistently satisfactory and functionally good cosmetic results. Thank you.
Any question? Next one. Okay.
Thank you.
Now we come to the end of the session. I'm sorry. I'm sorry, this is the next session. Some participants are there remaining. So next is Dr. Prabhakar Tripathi, prospective and study of the fluoroscopy guided cannulated screw fixation in pelvic ring and acetabulum fracture through percutaneous or mini incision technique.
Good afternoon to everyone. My study is prospective study of fluoroscopy guided converted screw fixation in pelvic ring and acetabulum fractures through percutaneous or mini incision technique. I'd like to thank my teacher, my guide, Professor Dr. Mahesh Bansal sir, for guiding me in this study. Coming to the introduction, the study for percutaneous or minimally invasive fixation of pelvic ring and acetabulum fractures and the technique utilized in specific pattern of fracture. Now in present scenario, ORIB is the standard method of treatment in pelvic and acetabulum fracture, but we tried something different and we innovate the thing and go to a further step for percutaneous approach. Percutaneous or minimally invasive technique may offer a short surgical time, less expenditure, less infection rate, and decreased soft tissue disruption. Data regarding percutaneous or minimal invasive technique in pelvic and acetabulum fractures are sparse in literature. Coming to the classification, we had used the Ewens and Borges classification in this study, and there are other classifications also there, like Tiles and others in pelvic fracture, and we used the Lieutenant and Judet classification for the acetabulum fracture, and we classify them, and accordingly we plan for our fixation and management further. And we also add a new classification for the screw placement or the technique which from which side we go, either antegrade or retrograde. Here the classification is Nakatani classification, while the fracture is divided into three parts from the pubic tubercle to the anterior iliac spine. There, where the zone 1 represent the most anterior part, and the zone 3 represent the most posterior part from anterior to posterior. And accordingly, at the zone 1 and 2, we can go retrograde, and in zone 3, and in zone some cases in zone 2, we can go from antegrade. This is the X-ray of hemipelvis, showing the different lines of acetabulum and pelvis. And this is our intra and post-operative X-ray views used in this study. And the permutation and combination of these four views also used during difficult in the reduction also. Our aim is to assess the outcome of percutaneous and minimally invasive fixation of pelvic and acetabulum fracture under fluoroscopy guidance. And the objective is to assess the post-operative anatomical reduction and stability of pelvic ring and post-operative 3D CT of pelvis and X-ray of pelvis and acetabulum, Judet view, inlet, outlet, and pelvis. To assess the clinical outcome of pelvis and acetabulum fractures after percutaneous fixation in terms of MATA radial field scoring. To assess the functional outcome of pelvis and acetabulum fractures after percutaneous fixation in terms of MAGI and Harry Field score. Our study materials method is study area is Department of Orthopaedics, SMS Medical College, Jaipur. And the study design is a descriptive type of observational study. And study duration was from November 2018 to the November 2019 with follow-up of the extra 1 year. And whichever is early, we have counted that according to case after 1 year follow. And the study was our inclusion criteria is both pelvic and acetabulum fracture dislocation undisplaced or displaced, but reduced by traction and manipulation under fluoroscopy or trochanteric traction during intra-op procedure. Fracture duration less than 14 days due to some reason, and hemodynamic stability, and patient who will give written informed consent and willing for follow-up. Our exclusion criteria is comminuted fracture and fractures that cannot be reduced by traction and manipulation under fluoroscopy. We had used 3 outcome variables. 1 is radiological and 2 is clinical outcome. The radiological outcome is MATA scoring system, and the clinical outcome we had used is Harry Field score and MAGIC pelvic score. This is our flowchart for our study. Coming to the surgical procedures, we used percutaneous fixation in 45 patients and mini incision through ilioinguinal approach, which is around 4 to 5 centimeter in lateral, ilioinguinal lateral side, and medial side modified stopa or vertical stopa, or in the standard stopa, which is also a mini incision with around 4 to 5 centimeter for medial window to reduce the displaced fragment. Coming to the surgical technique, these are the pictures A and B showing the retrograde insertion of pubic tubercle directed laterally to superior pubic ramus fracture. Diagram C showing the anterior column or acetabulum screw can be placed retrograde fashion during placement. The guide wire of the femoral nerve, artery and vein and spermatic cords nail could be injured. So precautions are taken, and the permutation combination of the fluoroscopy was used. And in diagram C, showing the retrograde pathway for placement of
Conclude your talk.
Okay, sir. Coming to the entry point, retrograde anterior column screw fixation. The point at entrance is medial to the pubic tubercle, and the confirmation was done in fluoroscopy. And retrograde posterior column screw fixation. The entry point is from the ischial tuberosity with hip and knee flexion. This is an example of the same case where the anterior and posterior column of the acetabulum of the right side was fractured, and we had used in a diagram D and E. You can visualize the retrograde fashion guide wire placement, and
Conclude your talk. Time is over. You are running very short of time.
This is a second example where the G, H, and I shows the CC screw placement intramedullary in both the columns. There is a anti-gate technique. For the anti-gate technique, these are ABC is the pictures we show, and these are the entry points for the anti-gate anterior column screw fixation. And here's the example of the anti-gate column fixation.
Please show your result last slide.
Okay, sir. All one. And surgical technique for the sacroiliac fracture or sacroiliac disruption of joint. For the anterior lesion or pubic symphysis lesion, we use internal fixation.
Show your last slide.
Okay, sir.
Take home message.
This is an example of sacroiliac joint fixation and anterior done in the percutaneous approach. And in follow-up with the MATA radiological at 12-month follow-up of radiological outcome, most patients 38 out of 54 had improved to excellent, and 1 had poor score. The p-value is less than 0.001.
Please show your last slide. You are not listening what you are saying.
Yes, sir.
You are continuous. The time is over. 3 minutes more.
Okay, sir.
Finish it.
Okay, sir. And the Harif score is also very significant. And the Magic score is also very significant. And advantage minimal in advantages of percussiveness and mini incision technique.
Are you listening or not? What have you have said?
Sir, this is
Finish,
last
stop it.
This is last slide, sir.
It is already more. There are so many speakers are waiting.
Yes, sir, last slide.
You are having
this
the 8 minute and you have taken the 13 minute.
No, sir, last slide.
You are allotted the 8 minute time, but you have taken the 13 minute.
The
Finish it.
advantages are minimal invasive, decreased hospital stay, less blood loss, decreased infection rate, and this is also comes under the damage control orthopedics, early rehabilitation, cost effective, less operative time. The limitations are the specific type of fracture.
All slides, just
Please skip and show your last slide. We have
we
given
can
4
see a
reminder to
picture.
here.
Okay,
What
sir.
does it mean?
Then we're coming to a conclusion. Percutaneous fixation of fracture of the pelvis and acetabulum is a relatively new procedure, and the indication for its use are not yet fully defined. The surgeon must always be prepared to convert to a formal open approach in the event of inadequate imaging or reduction by the percutaneous technique. Although inadequately reduced fracture treated by the percutaneous technique are unlikely to have a better outcome compared to
Okay,
the
thank you.
anatomical open reduction, the decreased complication
Doctor,
rate
thank
may
you.
be- Okay, sir. Compression rate allow the surgeons to accept the slightly more articulate discussion. Okay, sir. Thank you, sir.
You have to very particular about the time. For free paper, you are allotted the 8 minute. You have to finish your talk for the 8 minute. It is not 1 hour lecture.
Okay.
Everyone, please be careful about the time.
Any questions?
Any question? The next speaker is Montu Jain, modified stopard approach for the treatment of acetabulum fracture. Please be particular about the time. Try to finish your.
So greetings from AIMS Bhubaneswar, and I'll be speaking on our experience on modified Stoppa's approach in the acetabular fracture fixation. So we all know that the ilioinguinal approach has been the workhorse for acetabular fixation, particularly the anterior column. However, Stoppa approach was modified by Hirvaslo et al. And Cole and Hofner, who used for acetabular fixation, and later on some modification by Roca, Sagi et al. Have been made. So in the recent past, you can see a surge of publications in the Stoppa's approach, which shows its popularity. So here I will be presenting our experience in terms of fracture reduction, the functional outcome, and the complications. So this is a retrospective study from January 2016 to November 2018. Of the 45 patients, 26 had an anterior approach, of which 3 were excluded because 2 had a ilioinguinal approach and 1 had a follow-up of less than 2 years. The radiological assessment was done using an X-ray, the AP and the Judate's view, that is the iliac and the operator view, and CT scan were used for preoperative classification as well as postoperative radiological assessment. The functional outcome was done using the Harris-Hibbs scores. Statistical analysis was done by SPSS 20. The demographic data was analyzed using the descriptive statistics. So the approach is one which was described by Sagi et al., in which the surgeon stands on the opposite side and a Fenestrine incision is made 2 centimeters over the pubic symphysis. The rectus is split in the midline and partly erased from the superior pubic rami. The corona mortis lies 4 to 5 centimeters on the inner side of the pubic symphysis, and it is ligated or cauterized. And a lateral window is made liberally for implant fixation and also sometimes for putting the posterior screw. The anterior superior iliac spine can also be osteomatized for increasing the surgical view if required. So what we found that the mean age was 38.5 years with a high male is to female ratio. In more than 50% of our patients, we had a polytrauma, that is ISS more than 15. The most common mode of injury was a motor vehicle accident followed by fall from height. The interval between the injury and surgery was 12 days with a range of 4 to 21 days because a lot of patients are being referred from peripheral hospitals. Among the fracture pattern, we find that there is a large number of associated both column and transverse fractures with pure anterior column only seen in 4 patients. Coming to the outcomes, we find that excellent and good outcomes are seen in 17 patients, that is 74%, which are satisfactory. Among the radiological reduction, as per the MATA criteria, anatomical reduction, that is less than 1 millimeter, was seen in 12 patients. Imperfect reduction with a displacement of 1 to 3 millimeters seen in 9 patients, and poor reduction was seen in 2 patients. The median operative time was 155 minutes, and the blood loss was 650 ml, with almost 1 blood transfusion per patient. We had 1 patient of inguinal hernia, 3 patients of median nerve, operator nerve palsy, and 1 patient with a concomitant spine injury had a bed sore who required skin grafting. 2 patients developed grade 2 arthritis in the follow-up of 2 years. So this is 1 patient with a transverse fracture and a gull sign, and this is his functional outcome seen at follow-up. Another patient with an intercolumn and a posterior hemitransverse fracture, and he was radiological, and this is the initial postoperative radiograph, and this is his follow-up and final outcome, which is seen. Another patient with a transverse fracture, again with the impaction fraction of the dome and the head, and 1 supra and 1 infrapectineal plate was used. Another patient, another lady with a transverse fracture, and this was fixed with a good anatomical reduction. A patient with the anterior column and a high iliac blade fracture, and this had also excellent outcome. This is a patient with the associated bicolumnar fracture, and the iliac wing has been imperfectly reduced, but the acetabulum was reduced anatomically. This patient also had a complete dissociation of the acetabulum from the axial skeleton, and here both anterior and posterior approach was used. First a posterior and then an anterior approach was used. So we all know that the acetabulum fracture surgery is a highly demanding surgery because of the complex anatomy of the acetabulum, and the functional results depend upon a lot of factors, of which the most important factor is the reduction of the weight-bearing dome. Late presentation is very common in our country because of the inexperience of the trauma surgeons in dealing with the pelvic acetabular surgery. However, we got a reduction rate, satisfactory reduction rate in 90% because STOPA allows direct buttressing of the displaced fragment. Our functional outcome was also satisfactory in 74% of cases, and this is because of the heterogeneity of the fracture pattern what we find. There was also associated impaction fracture of the dome and the head, and as Marsh et al. Found out that the initial cartilage damage leads to early arthritis. So we had complication in 18%, but most importantly, no vascular injury was seen. Even by the masters such as Letterler and Jordet, they found 8% of the vascular injury with 3% of external iliac vein injury in 1 case of external iliac artery injury, and 1 femoral artery injury was seen in the series by Mata et al. So the big question arises, can STOPA really replace the ilioinguinal approach? So systemic review and meta-analysis by Wang et al. Show that there is decrease in operative time and definitely intraoperative blood loss, and the functional outcome are also comparable. In the same year, another systemic review and meta-analysis by Sanjay Meena et al. They found that there is a high anatomical reduction by using this STOPA approach with comparable functional outcome. So to conclude, chairpersons, STOPA is a very easy approach, approachable and reproducible even by lesser experienced surgeons such as us, because of its enhanced ability to reduce the fracture and fix the quadrilateral plate. The posterior column component can also be fixed either by using a long screw from the lateral window or by sometimes using an intrapelvic plate. And the Kochen-Langenbeck approach can be used to fix the wall fragment. And a single midline incision can be used to assess both side acetabular fracture. So in our opinion, STOPA approach is a viable alternative to anterior acetabular fracture fixation. Thank you.
Any questions from the audience? Thank you, sir.
Thank you.
Our next speaker is Dr. Jubair Yunus, indirect arthroscopy, distal clavicle resection, and institutional experience with midterm functional outcome.
Good afternoon, everyone. I'm Dr. Zubair, and here I'm to present my paper, Indirect Arthroscopic Distal Clavicle Excision in Acromioclavicular Joint Arthritis. As we all know, acromioclavicular joint is a relatively frequent source of clinical symptoms, most often due to primary osteoarthritis. It can also be the secondary osteoarthritis of the AC joint, particularly following trauma, infection, inflammatory processes, or due to distal clavicle osteolysis. Common problems of the AC joint are because there is a combination of 3 factors which underlies the frequency of the problems. First is that it is a synovial joint, which makes it vulnerable to the same processes as which affect the other parts of the body. Second, its superficial location and its relationship to the shoulder girdle, which predispose it to the traumatic injury. Third are biomechanics, which require it to transmit large loads across very small surface area, which result in failure with repetitive activity or overuse. Treatment options: first, we start with conservative management, activity modification, use of NSAIDs, passive modalities, local steroid injections, preventive therapeutic exercises. Operative management, distal clavicle excision is the standard operative treatment and can be performed either through open or arthroscopic techniques. There are certain disadvantages with the open distal clavicle excision, which include potential for the injury and weakness in the reattached deltoid and trapezius, increased post-operative recovery time, increased risk of infection, visible scar, and potential scar complications. So this study was done to evaluate the functional outcome of indirect arthroscopic distal clavicle excision in acromioclavicular joint arthritis. It was a prospective study conducted at the Postgraduate Department of Orthopaedics, Government Hospital for Bone and Joint Surgery and Associated Hospital of GMC Srinagar from July 2016 to July 2019 following approval by Institutional Ethical Committee. It was done on the patients diagnosed as having AC joint arthritis irrespective of their age and fulfilling the inclusion criteria. A total of 50 patients were taken for the study. Inclusion criteria was failure of conservative treatment, shoulder pain localized to AC joint, persistent pain in the absence of instability. Exclusion criteria was medically comorbid patients, active joint infection, persistent pain despite the injection of local anesthetic into the AC joint, neuroarthropathy, joint instability, MRI documented or arthroscopic findings, suggestive of major concomitant pathology like rotator cuff tear. Patients were evaluated clinically, radiographically, and followed by MRI to confirm the arthritis of the AC joint. Surgical technique, all the pertinent anatomy and portal locations were drawn on the shoulder. All portal locations were injected with a solution containing 0.5% xylocaine with epinephrine to prevent excessive bleeding. To provide adequate hemostasis, the systolic blood pressure was maintained around 100 mmHg if medically permissible. These are the intraoperative pics showing the entry into the posterior portal. This was an intraoperative arthroscopic image where we can see the rotator cuff attachment on the greater tuberosity. Once the glenohumeral portion of the case was done, the arthroscope was introduced into the subacromial space. The tip of the trocar was placed beneath the CA coracoacromial ligament and pushed out through the anterior incision. A 4 mm cannula was placed over the tip of the trocar and introduced into the subacromial space. The goal of this maneuver was to provide a room with a view. This was the anterior portal entry. The lateral portal was positioned approximately 2 finger breadths below the lateral edge of the acromion in line with the longitudinal axis of clavicle. It was used for the subacromial weaving and distal clavicle resection. With the shaver in the lateral portal and the camera in the posterior portal, the anterior edge of the acromion was cleared of soft tissues and a subacromial decompression was performed if indicated. Using a radiofrequency ablation probe, the anterior edge of the acromion and the acromioclavicular joint are debrided of soft tissue to identify the anatomy. The arthroscope was then removed from the posterior portal and placed into the lateral portal, and here we can see the head-on appearance when the manual pressure was applied on the distal end of the clavicle. Remaining soft tissues were debrided with a radiofrequency ablation probe. Bony resection of the distal clavicle was then started with a 5.5 mm burr through the anterior portal while weaving through the lateral portal. The inferior 1/3 of the clavicle was removed. Resection should ideally progress in an anterior to posterior and an inferior to superior direction. The goal was to excise the bone completely while leaving a periosteal tube behind. Using the 5.5 mm tip of the burr as a guide, 1 centimeter of the distal clavicle was accurately removed and checked arthroscopically. The arthroscope was also placed in the anterior portal to check if the distal clavicle has been completely excised. The post-operative rehabilitation protocol included a sling for post-op comfort for the first 10 days, and the pendulum exercises were performed regularly. Patients were examined at 1 week after surgery, then 2 weekly, and then the first 3 months, then once a month until the 6 months of surgery. Final scoring was done at 6 months of follow-up. The observations in our studies was mean age in our study was 49.5 years. Majority of the patients were females. Majority of the patients had right side involvement. Most frequent etiology was degenerative arthritis. The comparison of the mean range of the motion, the forward flexion improved from a mean of 104.4 degrees to 145.2 degrees at the final follow-up. Adduction improved from 8.92 degrees to 39.88 degrees at final follow-up. Abduction improved from 145 to 160.6 degrees at the final follow-up. UCLA score improved from a mean of 13.2 to 29.56 at the final follow-up, with significant improvement in the pain and the function parameters of the score. We had certain complications like persistent pain and intraoperative bleeding present in 6 patients each and stiffness in 4 patients. Certain photographs, this was a patient with the preoperative photographs, decreased forward flexion, abduction, and adduction. These are his preoperative radiographs, Zanka view, supraspinatus outlet view, and an MRI, axial MRI section showing the arthritis of the AC joint. These are the final follow-up pics, forward flexion, abduction, and adduction. And this was a radiograph at the final follow-up where we can see the distal clavicle has been dissected. There is adequate space at the joint. Discussion, the mean UCLA score improved from 13.2 preoperatively to 29.56 at the final follow-up. Excellent results were seen in 12% of the patients. Good results in 64% of the patients. Fair results in 16% of the patients, and poor results in 8% of the patients. Overall, 76% of the patients achieved excellent or good results, and 88% of the patients were satisfied. The mean duration of symptoms ranged from 4 months to 18 months with a mean of 8.08 months. Average length of the distal clavicular resection was 0.63 mm with 0.12 mm resection of the medial acromion. Conclusion, arthroscopic debridement of AC joint and distal clavicle excision through subacromial approach is a safe and effective procedure with very few complications. The subacromial approach gives us the added advantage of evaluating any glenohumeral joint pathology and subacromial pathology. Rapid rehab is possible in comparison to open procedures as there is less distortion of the deltotrapezial fascia and less soft tissue trauma permitting rapid return to activities. This procedure is associated with less pain and improved cosmesis in comparison to open procedures, though it has a longer learning curve and a technically demanding nature. Thank you.
Thanks, Dr. Jubair, for nice talk. One question from my side. Does you included chronic AC joint dislocation in this procedure?
No, sir. Dislocations, I have not taken dislocations in the last study.
Any question from audience? Okay, thank you. Our next speaker is Dr. Jaydeep Patel. He will going to speak on clinical and MRI correlation of ligamentomeniscal injury of knee with arthroscopy of the knee.
Next one, you know, next year.
Good afternoon, everyone. Myself, Dr. Jaydeep Patel from SN Medical College, Agra. My topic is clinical and MRI correlation of ligamentomeniscal injury of knee with MRI with arthroscopy of knee. Introduction. Assessment of ligamentomeniscal injury of knee begins with clinical examination and special test, which include anterior drawer, posterior drawer, Lackman, Matt-Murray, Barras, and Balgas tests. MRI scan of knee has been significant advances since its initial application for evaluation of ligamentomeniscal injury of knee. MRI is a non-invasive modality, hence routinely used to assess ligamentomeniscal injury of knee. Nowadays, arthroscopy has been a gold standard to diagnose the intra-articular knee pathology, but it is in an invasive procedure and can cause operative complication. Aim of study. The aim of our study is to correlate clinical and MRI finding of ligamentomeniscal injury of knee with MRI with arthroscopy of knee. Material and method. It is hospital-based interdepartmental study. Sample size is 60 patients and time duration is 2 years. All patients were subjected to clinical examination, MRI, and followed by arthroscopic evaluation. Clinical examination included Lightman anterior drawer is for ACL, posterior drawer test for PCL, Matt-Murray for medial and lateral meniscus tear. The supervisor from Department of Radio Diagnosis give a detailed report of MRI finding. Arthroscopic examination is considered as a routine procedure under spinal anesthesia. Inclusion criteria. All adult patients with history of significant knee joint injury presenting for treatment or follow-up in Department of Orthopedic Surgery and OPD at our institution for suspected ligamentomeniscal injury of knee. Exclusion criteria. Patient with contraindication for MRI, patient less than 18 years of age, patient with post-existing knee joint pathology, patient who have had a previous arthroscopy reconstruction. Result. A total 91 injuries were evaluated clinically. On MRI, it was found 124 and on confirmation with arthroscopy, it was 99. This is the table form of previous slide. Like total 42 ACL injury diagnosed on clinical examination. On MRI, it was 52, and on arthroscopy, the injury confirmed was 44. Clinical and arthroscopic correlation. In this study, 42 ACL injuries were detected clinically. And on arthroscopy, 44 ACL tear were detected with sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of 95.65, 100%, 100%, 88.89, and 96.7% respectively. 6 PCL injury were detected clinically as well as arthroscopy, so all the parameters are 100%. On clinical examination, 25 medial meniscus injury were detected, and on arthroscopy, it was 28. So the parameter are 84.85, 94.11, 93.33, 86.48, and 89.55 respectively. And we found 18 in lateral meniscus injury on clinical evaluation, while on arthroscopy, 21 lateral meniscus injury were detected with sensitivity, specificity, PPB and PB and accuracy of 80.76, 95.12, 91.30, 88.63, and 89.55. And this is the table form of previous slide. Total 42 ACL injury diagnosed clinically, and on arthroscopy, there are 44 ACL injury detected. This is the table of previous slide, table form of previous slide. MRI and arthroscopic correlation. Sorry, slide again. And now MRI and arthroscopic correlation. In our study, 52 ACL injury were detected on MRI compared with arthroscopic finding. 44 ACL tear were detected with sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of 97.77, 64%, 83.01, 94.11, and 85.7% respectively. In our study, MRI detected 38 medial meniscus injury, and on arthroscopy, medial meniscus injury was detected in 28 knee injuries with sensitivity, specificity, PPB and PB, and accuracy of 96.55, 74.42, 71.79, 96.97, and 83.33. In this study, 8 suspected PCL injury ACL cases were diagnosed on MRI, and on arthroscopic examination, 6 patients had confirmed PCL tear with a sensitivity, specificity, PPB and PB accuracy of 100%, 96.43, 75, 100, and 96.77%. And like that lateral meniscus injury, the following parameter are 87.5%, 82.97, 72.41, 92.85, and 84.50. This is the table form of previous slide. ACL, like 52 ACL injury diagnosed on MRI, and on arthroscopy confirmation, there was only 44 confirmatory injury. And this is the table form of previous slide. All the parameter, positive predictive value, negative predictive value, sensitivity, specificity, and accuracy of various ligamentomeniscal injury. Discussion. Clinical examination may be difficult in acute injury and with injury with multiple ligament and meniscus. MRI being non-invasive and highly sensitive tool of investigation, early and subtle changes in soft tissue often picked up by MRI. Arthroscopy being highly sensitivity and invasive specific procedure in both diagnostic and therapeutic, but it is invasive and has complication associated with it, thus limiting its use as a diagnostic modality alone. And this is a clinical and arthroscopic correlation of those ligamentomeniscal injury compared our study compared with the various other study and found similar result. This is MRI and arthroscopy, and MRI and arthroscopic correlation of ligamentomeniscal injury and our injury comparison with various study previous study following similar result. Case 1, 25-year-old male presented with
left to conclude. 1 minute left.
Okay, sir. 25-year-old male presented with complaint of instability and give away of right knee and difficulty climbing and walking, running. Clinical examination, anterior draw test positive, ligament positive. On MRI, we diagnose ACL tear and confirm with arthroscopy. And in second case, clinical examination show anterior draw test positive, ligament test positive, but on MRI we found ACL with medial meniscus tear, but on arthroscopy only ACL tear and intact medial meniscus. Conclusion. In our study, clinical and MRI correlation of ligamentomeniscal injury of knee with arthroscopy of knee, we conclude that carefully performed clinical examination can give equal or better diagnosis of ligamentomeniscal injury in compared to MRI scan. MRI is a useful non-invasive modality having high diagnostic accuracy, sensitivity, and negative predictive value, making it a very reliable screening test for diagnosing ligamentomeniscal injury of knee. So MRI scan may be used to rule out such injury due to high negative predictive value. MRI scan has a much better NPV than positive predictive value in both meniscus and ligament injury. Arthroscopy is gold standard for ligamentomeniscal injury, but it is invasive procedure. So when clinical sign and symptom are inconclusive, performing an MRI scan is likely to be more beneficial in avoiding unnecessary arthroscopy surgery. Thank you.
Thank you, Dr. Jaideep. Any questions? Okay. Our next speaker is Dr. Danish. ACL reconstruction of knee using peroneus longus tendon and clinical evaluation of donor site mouth. Next one not there. Okay. Now we proceed to Dr. Rajesh Kushwaha. He is speaking on comparative study of single bundle ACL reconstruction using the peroneus longus tendon versus hamstring tendon.
Good afternoon. My topic is comparative study of single bundle anterior cruciate ligament reconstruction using the peroneus longus tendon autograft versus hamstring tendon autograft. Knee is a major and complex hinge joint, and stability of the knee joint and motion are basically controlled by the multiple ligaments like ACL, PCL, median and lateral meniscus, joint capsules, and muscles which are inserting at the knee joints. The ACL run diagonally in the middle of the knee joint in the intercondylar notch. It prevents the tibia from sliding out in front of the femur as well as rotational stability to the knees. Incidence of ACL injury in general population is 1 in 3,000 population per year. Most common mechanism for sustaining an ACL injury is valgus stress with tibial external rotation at the knee joint in a flexed position and foot grounded position. ACL injury incapacitated for certain sports activities and predisposed towards meniscal and cartilage lesion, and if left untreated may evolve to arthrosis. ACL can be reconstructed either conventional open method or by arthroscopic method. Arthroscopic reconstruction of ACL has several advantages, like it is a minimal invasive procedure, higher accuracy for graft placement, less disturbance to normal surrounding tissue leading to faster recovery and rehabilitation, less stay in the hospital, and minimum infection in the post-operative phase. ACL reconstruction improves knee stability and function with many graft types, either autograft or allograft. Ideal autograft should have following natures. It should have acceptable strength, acceptable adequate size, easy and safe to harvesting, and minimum donor site morbidity. Commonly harvested autografts are bone patellar tendon bone graft, hamstring graft, or peroneus longus graft. Each graft has its advantage and disadvantage. Hamstring tendon graft has advantage of easy to harvest, minimal donor site morbidity, and strength comparable to native ACL. Disadvantages are unpredictable graft size, potential decrease in hamstring power. Bone patellar tendon bone graft have advantage of bone to bone healing is faster in this graft type. Disadvantages are it requires large incision, anterior kneeling pain is chief complaint. Post-operatively, there is the risk of patellar fracture, fixed length of the graft, and weaker than the native ACL. Strength and mean thickness of the peroneus autograft is nearly same as that of native ACL, and it is very easy to harvest. Removing of peroneus longus tendon has no effect on the stability of the ankle joint. Method of the study. We included the patient who reported to the Department of Orthomedics SMS Hospital, Jaipur during the period of November 18 to October 20. It is a prospective comparative randomized interventional study. Sample size was calculated 28 cases in each of two groups. Total 56 cases was operated. Randomization done by chit box method. Flowchart. Patient at outdoor of SMS, then assessed for the eligibility according to the inclusion criteria and exclusion criteria. Informed consent and baseline data was collected.
Randomization done by check box method and allocated in two group, either peroneus group or hamstring group, graft harvested, and then reconstruction done by the peroneus and hamstring tendon in both of group. Follow-up done on 14 day, 2 months, 6 months, and 1 year, then outcome analyzed and outcome inference made. Aim of the study to compare outcome of arthroscopic single bundle anterior cruciate ligament reconstruction using the peroneus longus tendon autograft versus hamstring tendon autograft with following objective like postoperative knee stability, subjective knee functions, patient satisfaction, graft site morbidity, and range of motion. Grading of the injury, there are the 3 grade. First grade, there is the minimal number of the ligament fiber destruction, and there is no stability to the joint. In second degree sprain, more ligamentous fiber disruption occurs and mild to moderate instability is noted. In third degree sprain, complete disruption of the ligament occurs and there is marked instability of the joint. Clinical test done for ACL insufficiency is anterior draw test, Leachman test, and pivot shift test. On pivot shift test, on the basis of these tests, baseline data was collected pre-operatively. Primary signs seen on MRI was non-visualization of the ligament, complete disruption of the ligament segment, abnormal signal intensity in the T2-weighted image of the ligament path. Alteration of normal linear configuration, linear angulation, or contour of the ligament was primary sign. Secondary sign on MRI was abnormal bony contusion on posterolateral tibial plateau, second fracture, and lateral femoral condyle. Anterior tibial translation more than 5 mm, and uncovering of posterior horn of medial and lateral meniscus. These are secondary signs on MRI. Surgical technique after peroneus graft, for peroneus graft harvesting, a 3 centimeter incision was marked 2 to 3 centimeter above and 1 centimeter behind the lateral malleolus. After skin and subcutaneous incision cut, peroneus longus tendon identified, and this tendon cut above at the level of near superior border of retinaculum, distal stump of the peroneus longus tendon sutured side to side with the peroneus brevis tendon and tendon stripped with the tendon stripper. Graft prepared and arthroscopically graft placement was done. Results of the study. Mean age in the peroneus group was 28.8 year and hamstring group was 26.6 year. Mostly were male in both the groups. Most common mechanism of injury was activity of daily living, and patient reported within 3 months of injury in peroneus group was 22 and hamstring group was 18 in number. Right sided was affected in 13 patients in peroneus and 20 in the hamstring group. Comparing of graft diameter. Mean graft diameter in peroneus was 8.8 mm, in hamstring group was 8.1 mm. There was mean difference of 0.7 mm. On Leachman's translation 1 year postoperatively, 3 to 5 mm translation was shown only by 7.2% cases peroneus and 10.7% cases of hamstring group. Donor side morbidity of the ankle was calculated by the foot ankle disability index score. And thigh hypertrophy 1 year postoperatively more than 20 mm was noted in 8 cases of hamstring group, while none of the peroneus longus group. Lack of extension at 1 year, 3 to 5 degree lack of extension was seen in 1 case of peroneus and 2 cases of hamstring group. Same results was seen in the lack of the flexion moment.
1 minute left.
Single leg hope test, 17.9 cases and 25% cases of the hamstring group were able to do single leg hope test with 76 to 89% accuracy. On IKDC score comparison, IKDC score in the range of 85 to 95 was shown by 92.8% cases of peroneus and 89.3% cases of hamstring group. Rehabilitation, during first 2 weeks, the goal of the rehabilitation is to attain full knee extension and flexion 90 degree, and main focus was on pain and swelling control. Week 2 and 3, the main goal is maintain full knee extension, achieve 90 to 120 degree knee flexion, and develop enough muscular control to wean off knee immobilizer. 3rd to 4 week, the goal is to achieve full range of motion and strengthening exercises. 6 to 12 week, we add the treadmill and can begin outdoor bicycle riding on flat road. 3 to 5 months, goal is to introduce jogging, light running, and agility drills. 6 months, return to sports. Return to sports is advised if there is the quadriceps and hamstring strength at least 80% of the normal leg. Patient is able to complete running program and full knee motion and good stability of the knee joint. This is the case study. Sresh, 22-year male, resident of Martinagar, Saganer, football player who who met a trauma during football playing, reported to SMS hospital during June 19, operated with peroneus longus autograft. 1 year post-operatively, patient is able to do his routine activity and able to play football very well. Summary of the result. Majority of study subjects were male, 51 out of 56. Mean age was 28.8 in peroneus and 26.6 in hamstring group. And right side was affected 33% and left in 23%. Most common mechanism of injury was activity of daily living in 29%. Mean graft diameter was 8.8 in peroneus and 8.1 in semitendinosus group. Mean IKDC score was 92.3 in peroneus group and 90.1 in hamstring group. Only 7.2% of peroneus and 10.7% of hamstring group have ACL laxity in the range of 3 to 5 mm after 1 year of surgery. And 1 month post-operative follow-up, 24% of hamstring group complained lack of sensation in infrapatellar area, possibly due to damage of infrapatellar branch of saphenous nerve, which recovered spontaneously on following visit. Conclusion: in this hospital-based prospective comparative randomized interventional study for single bundle ACL reconstruction, peroneus longus tendon autograft found superior to hamstring autograft in terms of excellent functional outcome, more strong and thicker graft, knee stability, and showed good result to the 4-stent hamstring tendon with no graft site morbidity. Thank you.
Thank you, Dr. Rajesh. Just one question from my side. After harvesting peroneus longus tendon, did you tie the distal part to the pelvis?
Yes, sir. Remaining stump of the peroneus longus was tenodesed with the peroneus brevis tendon with ethibond 2.
Reason for tying?
Sir, peroneus brevis and peroneus longus are synergistic muscle which act synergistically to eversion of the foot. So, along with the peroneus brevis pool, the remaining stump can also cause eversion.
Okay. Next speaker is Dr. Ajit Singh.
Thank you.
He is going to, no? Okay. This is the end of the session.